its unique challenges, has had to navigate a pandemic which has taken a toll economically, socially, physically, and mentally, to name a few. However, in Trinidad and Tobago, and I am sure it applies across the world, it has also encouraged ingenuity, innovation, and resourcefulness. It gives me pleasure to welcome you all to the second day of the Second Caribbean Organ Donation and Transplantation Summit, which is being hosted by the North. This virtual platform has allowed collaboration with National Organ Transplant Unit, the Donation and Transplantation Institute of Barcelona, and Caribbean neighbors. In spite of many restrictions to travel and mass gatherings, this program promises to be thought-provoking and would hopefully be the stimulus needed for the implementation of a meaningful partnership amongst Caribbean island states with regards to organ donation and transplantation. To you, the attendees, let this be part of the ongoing conversation with your clients and not just an afterthought. Once again, welcome. Have an enjoyable summit.
Thank you for that warm welcome, Dr. Arthur. Our keynote speaker for today is Dr. Maria Paula Gomez. She'll be presenting the importance of a Caribbean organ donation network. Dr. Maria Paula Gomez is specialized in health management programs. She obtained her master in donation and transplantation of organs, tissues, and cells from Barcelona University. Dr. Gomez has 19 years of experience leading change processes in healthcare systems around the world. She is currently the Executive Director of the Donation and Transplantation Institute, DTI, in Barcelona, and the Medical Coordinator of the International Registry for Organ Donation and Transplantation. She is Counselor of the International Society for Organ Donation and Procurement, and a member of both the Transplantation Society and the European Donation and Transplant Coordination Organization. She is also a professor in the International Master in Donation and Transplantation of Organs, Tissues, and Cells at the University of Barcelona. In her role as Medical Director at the Donation and Transplantation Institute from 2008 to 2013, Dr. Gomez was responsible for designing, leading, and coordinating the implementation of leading practices in organ donation in the Middle East, the Caribbean region, and European countries. Her contribution in Europe supported the improvement of current leading models that now achieve high performance. Dr. Gomez, over to you.
Thank you very much, and good morning, everyone. I would like to say thank you to the North Branch Trinidad and Tobago Medical Association for inviting me to talk today, and also to Hasina to contact me and to invite me to talk in this important event. I will share my screen so we can start the presentation. Can you see my screen?
Yes, we can.
Okay, so today I will talk about the importance of a Caribbean organ donation network, and I divide my presentation in three main blocks. The first will be a little bit of background, how is the current situation in organ donation and transplantation worldwide. Then an organ donation networks worldwide, and finally I will explain a little bit how this Caribbean organ donor network could be a reality. So regarding the activity worldwide, this figure is from the International Registry in Organ Donation and Transplantation, and is the actual disease organ donation rate in 2019. So we can see in the left side of the figure, Spain with 49 donors per million of population. Also from Europe, we can find Croatia, Portugal with 34, 33, France, and Belgium with 30 or up to 30 donors per million of population. Outside of Europe, we can find United States with 36 donors per million of population. The ones who are not familiar with the donation model, Europe and America, they have two different models. European model is more based in hospital transplant procurement managers, while American model is more regarding organ procurement organizations that are located outside of the hospital. Then in the other side, we have Trinidad and Tobago here with, sorry, this is kidney transplantation. Yeah, actual disease organ donation. We have here Trinidad and Tobago with 0.7 donors per deceased donor per million of population. But yesterday we heard that Trinidad and Tobago achieved 3 donors per million of population in a few years ago. Regarding kidney transplant from deceased donors, so we have Spain, France, Finland, Czech Republic, Spain with 72 donors per million of population, France with 55 kidney transplant per million of population. And Trinidad and Tobago last year was in 1.4 kidney transplant from deceased donor per million of population. What happened with the liver in the world? Well, the biggest one is Croatia, Spain, and United States with 30, 26, and 25 liver transplant from deceased donor per million of population. Heart, we have United States with 10 heart transplant per million of population, following by Slovenia and Croatia with 10 and 9 heart transplant per million of population. Something important I want to call your attention is Slovenia, which is a very small country in Europe with about 2 million of inhabitants and has a very high heart transplant rate. So we will see that this is because of this cross-border network of exchange of organs exchange. We will go through that in the future slides. And then lung transplantation, the first in the world is Austria with 11 lung transplant per million of population, following by Belgium and Canada. And then Austria also is an example of how the cross-border exchange, organ exchange works. Austria is also a country with 7 million, 8 million inhabitants and has a very the highest rate of lung transplantation in Europe. So we will see how this cross-border organ exchange works in that sense that one country like this has a very high lung transplantation rate. What happened with other type of donor after circulatory death? For the ones who are not familiar, the typical type of donation is brain death. But then the countries start to develop a new type of donation, which is donor after circulatory death, which means when the heart stops and then new maneuvers are implemented in order to be able to recover organs. So DCD donors could be controlled or uncontrolled. And then the majority of the countries right now, they are implemented controlled DCD donation. That controlled DCD donation is related with withdrawal treatment in the patient who are declared with futility of the treatment or poor prognosis. So in DCD organ donors, we have Spain with 15 DCD donors per million of population, following by Belgium, United Kingdom, and Netherlands. It's important to say that in Trinidad and Tobago, it doesn't exist DCD donation yet, but it's something that is possible to develop in the future. And then important to tell you that actually in 2019, 25% of the donation in Spain come from DCD donation. So it has a very huge potential. And then this is a similar figure just to compare or to see each of the countries in relation of DVD and DCD. And then you can see that not all countries develop DCD programs. They have a special complexity. So the recommendation for any country who wants to start disease donation is DVD, and then slowly progress to DCD, maybe first control DCD and then uncontrolled DCD. So as I mentioned to you, Spain, 25% of the donors come from DCD, and the highest countries with DCD rate is United Kingdom, Australia, and Canada. well, followed by Netherlands as well. It has a highest activity in DCD. Let me see if I say Netherlands, yeah, with 8.8 DCD donors per million of population. What happened regarding living donation? Well, in living donation, the scenario changed completely. Spain is here with 7 living donors per million of population, a very low rate. And then the highest in the world is those countries with a very low disease donation activity. So we have Turkey, the first one with 53 living donors per million of population, following by South of Korea, Saudi Arabia, and Netherlands. We have here Trinidad and Tobago with 2.9 living organ donors per million of population in 2019. Kidney transplantation from living donor as well, Turkey, Saudi Arabia, Netherlands in the top of the list with 36, 29, and 28 kidney transplant from living donors, and Trinidad and Tobago here with 2.9 kidney transplant from living donors. And lastly, liver transplant from living donors. We have South Korea, Turkey, and Saudi Arabia also, where the three in the top list of living transplantation. With 22, 16, and 7 liver transplant per million of population from living donation. Okay, those are the scenario in the world of organ donation and transplantation. What happened regarding organ donor networks worldwide? So before to go to explain you the different organ donor networks, I like to mention you these 3 circles, or something that is called the golden circle. And why I bring this today is because when we start a new idea, a new change, or a new plan, or activity, everyone or the majority of the people think about the what and the how. No, what I have to do, or how do we do, how I have to do this new activity. And the recommendation always is to start for why we have to do this. So the invitation today is to start to think why we have to implement this Caribbean organ donor network. And to answer this, so I have here a rationale, why a cross-border exchange of disease organ donors could be beneficial for a region. So the first thing is because we will have more organs. We could have more organs if we exchange organs across border, and to have more organ offers, we will have the opportunity to a better match with a list of recipients. So we know that the better match, the lower the risk of a rejection and the loss of an organ. So we will improve the short-term and the long-term of outcome for transplantation. So international cooperation is good for survival rates and quality of life after transplantation. What else? We know that if we have more organs offers, so a number of specific patients groups will have a better chance of receiving a suitable donor organ in time. So we are talking about the emergencies or the urgencies for transplantation, for heart, for lung, for liver. We are talking about hypersensitized kidney patients and, for example, pediatric cases. So those patients will have a major opportunity for transplantation. What else? We can increase the use of available donor organs, especially marginal organ donors. We know that sometimes a country has not the enough capacity or the possibility to use marginal organ donor for different reasons. So if exists this cross-border exchange of organs, will be possible that centers from other countries, they use this marginal organ donor or expanded criteria donor, or that we can obtain a donor from almost all hospital or a small donor hospital. No, talking, for example, countries that they will not have transplant program, but they can have recipients, they can have donors, and then those 2 type of patients can be transferred to a country or a region where there is a transplant program. What else? Why? Optimization of resources. So working as a network, same resources will support more process. So it will be possible to decrease the cost of operation. We can centralize a database of recipients and donors, centralize laboratory, share recovery teams, increase access to transplantation, as I mentioned to you. Countries without transplant service or transplant centers could be benefit for transplant service for another near country. And knowledge and research, cross-border waiting lists, and the fact that this database contains all the available information on donors and recipients offer the great advantage of providing a source of knowledge and platform for information sharing and research. Yesterday, we heard the presentation of Dr. Soibo that also mentioned about the Caribbean registry, the importance of have a centralized, consolidated registry to take decisions or for the policymakers and to do the research. What are the risks of these cross-border networks? The first thing is to create donor countries versus transplant countries. So how we can mitigate this risk, the prioritization of local patient on waiting lists. What this means that when there is a donor in a country, so the donor country will have the first match with the recipient from their own country. So the organ offer occurs only when there is not matching recipient on the national waiting list of the donor country. And of course, there will be a specific rule for emergency cases. The other possibility is the donor country also has, the recipient has no transplant program, but then donor and recipient travel to the transplant center and then it will be possible to receive this organ. The other risk or a major limitation factor in this international organ exchange is the cool ischemia. So the organs, especially some organs, has a very short cool ischemia time. So long distance transport will go against this possibility. Of course, with the development of machine perfusion techniques, the possibility to avoid this problem in the future is high. And the other risk is to create an entity with excess of bureaucracy and control or supervision and monitoring, no? That in some cases it could happen, no? It's a risk. So the important to really identify the people and the structure and infrastructure that this supranational organization will need. And then I will bring you some example of this that is already happening in the world. One of them is Eurotransplant, maybe is the biggest one, is the Eurotransplant International Foundation. This is a non-for-profit international organization. It was founded in 1967. The founder was the Professor Van Roodt. And basically that he observed something that we already know is that HLA will play an important role for a good result in transplantation. So he thought that maybe sharing organs between different centers will increase the possibility to a better match. It was the basic philosophy. So it started with 12 transplant centers in 3 countries that they participate in a voluntary basis. And this is very important because sometimes we wait till government organize, till government and politics agree in some laws and some decision, and sometimes only people make change to happen. So the idea that 12 transplant centers decide to participate and create a network that currently still is working quite well. So the idea of this was that every donor of this center was reported to Eurotransplant in order to select the patient with the best possible match. And it was a patient-oriented allocation. So the best match will receive the organ. We will see that there are different organ allocation systems. So we will see which one could work for this cross-border organ exchange network. So right now, Eurotransplant 2019 is 8 countries, 137 million of people, 80 transplant centers, 71 for kidney transplant, 39 for heart transplant, 22 lung, 38 liver, 38 pancreas, and transplant programs, sorry, and 208 transplant programs. This is transplant programs, and 80 transplant centers, as I mentioned to you. Here we can say Germany 44 transplant program, Netherlands 10, and so on. What happened last year? They have 2,000 disease donors. They monitor, organize, or coordinate 2,000 disease donors. From these, 6,900 organs were transplanted, and here we can see the different type of organs. 3,000 for kidney, 1,500 for livers, and so on. And more or less, they have near to 14,000 patients in waiting list. Something very important is only 21.5% of the organs obtained were exchanged cross-border. No, the rest remain in each of their own countries. So one of these rules that we mentioned before, the donor country has the right to allocate first the organs in their own waiting list if there is not an emergency case or a special recipient. So it happened in Eurotransplant in last year. And how is their function and operation? Where is a mediator between donor hospital and transplant center, facilitate allocation and cross-border exchange, 24/7 organ allocation service, 24/7 immunological support, although each country has their own tissue typing lab, online waiting list data entry, online donor data entry services, and evaluation post-transplant results with follow-up registry. Some of the main activities that they perform. They have an advisor committee for each of the transplant program, plus donation, tissue typing, ethics, and registry. They elaborate recommendation of new allocation rules, but together with the advisory committees, with national scientific transplant organization and the national authorities from each of the countries that are part of Eurotransplant. Eurotransplant has agreements, national agreements with the National Transplant Organization of the Minister of Health, and how Eurotransplant is financed by health insurance companies from the participating countries and from the National Transplant Organization in the countries where there is a universal healthcare coverage. Not everything is good. I just bring this to you. Lesson from the German organ donation scandal. I don't know if you were aware, but a few years ago, four doctors in German hospitals, they manipulate the organ transplant allocation system. They manipulate the medical records in order to prioritize or in order to have a higher priority for received organs. So the conclusion of that was that Eurotransplant had a program of external audit that failed to detect the abuse. You know, in that time, Eurotransplant was the responsible to control the admissions to the waiting list, or to supervise the admission to the waiting list. And then they discover a leak or a fail in this process. So everything is not perfect as usual. Other example of cross-border organ donation and transplant network, we have Scandia Transplant, which is Denmark, Finland, Iceland, Norway, Sweden, and Estonia, working quite similar at Eurotransplant. Near to this region, Uruguay and Argentina. Many years ago, Uruguay has not liver transplant program yet, so they send the liver and the recipient for the liver to a transplant center in Argentina. So they share organs and recipient. The recipient receives the liver and then come back to Uruguay for the follow-up. Currently, now Uruguay has a liver transplant program. Currently, SCOT and Middle East SCOT is Saudi Center for Organ and Tissue Transplantation. And then SCOT is supporting other countries around in the Middle East, like Emirates, and they share recovery teams and organs. So 3 years ago, Emirates has not a heart transplant program or liver transplant program, but has donors. So SCOT, Saudi Center, flew from Saudi to Emirates with recovery teams, with all the material, and performed the recovery of the liver, the heart. The kidneys remain in Emirates for transplantation, and the other organs went to Saudi. Right now, Emirates has a liver and heart transplant program, sometimes has not a recipient compatible, so the organ, the heart or the liver is recovered in Emirates by the local teams, and Scott Saudi Center send the plane to pick up the organs and come back to their country. And then last, Spain, Portugal, France, and Italy will also share organs and recipients. For example, a few years ago, Portugal sent lung recipients to Spain, to Galicia, to be transplanted in Spain. And of course, Portugal sent the organ, the lung, from the deceased donor and the recipient, and Spain, Galicia, transplanted the organ, and then the recipient come back to their original country. This is a summary of all organs sent, this is sent in light green, and all organs received from Europe in Spain. So basically, Spain sent 2 intestines, 59 lungs, 101 livers from 1990 till today. 260 heart and 300 kidneys. On total, 700 organs have been exchanged across from Spain to the rest of Europe. And then the last part is the Caribbean Organ Donor Network. So here we are in the Caribbean community, 18 millions, a GDP in average of 15,000, a Human Development Index of 0.7, which is referred as a high, with a lot of variability, of course. And then what we need? No, we need multi-organ transplant hospital, a donor hospital network, a regional data center with a waiting list management, an organ allocation and sharing system, and especially collaboration and a good logistic organization. So regarding multi-organ and transplant hospital, this is the list of the countries, and we know that 6 countries currently has a living transplant program, living kidney transplant program, and Trinidad has a living and deceased transplant program. This is from the Global Observatory, and this is the per million population per kidney transplant center in 2019. This is the top 5 countries in the world doing kidney transplantation, and then the average is 1.2 million of population per 1 kidney transplant center. So if we move this to the Caribbean region, Trinidad is 1.3, Jamaica is 2.9, and in total the Caribbean network is 3. So still there is some room for improvement. And then regarding other organs, for liver transplant center is 2.4, heart 2.9, lung near 5 population per million per transplant center. What I want to say, well, we need to create these transplant programs, we need to train, and we need to create the transplant programs together with the recovery teams. What happened with the donor hospital network? Well, I will say that all countries, almost all countries, should be able to be part of this donor hospital network. And then each of them will account with a TPM. We should create this TPN network. The organ donation potentiality based on the World Health Organization estimation of mortality in 2008, it's a little bit old, but also considering an average, no ideal donation rate, average donation rate of 12 donors per million of population, the potentiality of this Caribbean network will be about 53 disease organ donors per year. We are talking about 212 organs if we are considering 2 kidneys, a liver, and maybe a heart. Regional data center and waiting list management. This is centralized, where the system will receive the recipient characteristics, the donor characteristics. Of course, it's very important to agree the rules for inclusion, for management of the waiting list, no inclusion of the patient, and so on. And then the same system will be responsible to do the match. This is from Eurotransplant, so we don't need to invent something that already exists and is working in other regions. Organ allocation and sharing. So this is that I mentioned to you before. There are in general two types of organ allocation system. One is patient-based. So the best in the list is the one who received first the organ, and the other one is centers-based, which means, for example, that where the center who has the donor is the center who will have the opportunity to do the transplantation. So just to let you know, Spain, we have the two systems combined. So we have center-based and patient-based. Why? Because the center who has the donor, if it's a transplant center, will have the priority to allocate the organs to the best recipient in their own waiting list. But if not, so we use the regional, the center-based. I mean, we can offer to the other center in the same city, in the region, in the zone, and if not, in the rest of the country, and if not, we offer to the rest of Europe. The most important for the Caribbean Network for Organ Donation and Transplant is the prioritization of local patient on waiting lists. So, as I mentioned to you, it's happening in a small scale in Spain. And the importance of the transportation, no, 24/7 availability for transportation, that maybe it could be a challenge in the Caribbean region. So lastly, collaboration and logistic. And then I found this article from 2014 in the Global Health Promotion, which is the improving the health status of the Caribbean people, some recommendation in a summit that they have. And then I think that we can homologate for our matter today. No? The first thing is the policy and governance. We know every country has the authority and their own health policy and governance, so it will be a challenge to try to align, if not all of them, the majority of them in this kind of Caribbean network. The resources, so limited resources that prioritize to address acute care, but I have to say that yesterday was 2 or 3 presentations point out the big benefit of transplantation versus dialysis, and the countries, the Caribbean countries right now, they are supporting or sponsor dialysis. So organ transplantation or kidney transplantation is cheaper than dialysis. And then we should acknowledge these partnerships with private and non-governmental bodies to execute health, and it should be considered. Communication and community engagement, of course, this is something to be transparent to the community, especially the government institutions need to foster trust and facilitate an environment of collaboration. And finally, lack of skilled healthcare professional. Fortunately, we have kidney transplantation ready to start, and also from not living is happening, and from disease is ready. It's a matter to create the network. But for the other organs, liver, heart, well, there will be the need to create a training plan for those organs. As a conclusion, it's not a dream. I really believe that it could become a reality in different phases of development, but then kidney transplantation from living donation is a reality already in Caribbean countries. The needs to develop a disease donation program, we are talking about between 18-20 million of inhabitants. As I mentioned to you, you have Caribbean countries has everything to implement disease donation. So it's something that is possible to happen. Need to develop transplant program of other organs and tissue. We cannot forget tissue, which is they are also in a huge demand in the region. And then to maximize benefits and program sustainability, the collaborative approach could be the better option for the region. And the challenge is the service exchange. There is not any precedent of this before, as far as I know. Financial support and the logistic to be able to, disease donation happen 24/7. So the system should be ready to work 24/7 anytime. And I think that my time is now finished. Thank you very much. And I will be here to answer any question or happy to hear comments about this idea from the audience. Thank you very much. Hello?
Thank you for that very informative presentation, Dr. Gomez.
Yes, yes, yes.
We have lots to look forward to in the future.
Sorry?
Thank you for that informative presentation. We have lots to look forward to in the future.
Thank you.
Okay. In the interest of time, we ask all our participants to write down all your questions, and we'll have one question and answer session at the end. Also, to our speakers, you may hear 2 bells, one 5 minutes prior to the end of your allotted time, and then at the end of your allotted time. So our next speaker is Dr. Narissa Jurawan. Dr. Jurawan began her career in nephrology as a renal registrar at the Eric Williams Medical Sciences Complex in Trinidad and Tobago. She then spent 8 years in England, where she completed higher training in nephrology at the West Midlands Deanery in the United Kingdom. And she was awarded a specialty certificate in nephrology by the Royal College of Physicians and the completion certificate of training in nephrology by the General Medical Council of the UK in 2016. Upon completion of her specialist training, she went on to work as a consultant nephrologist at the University Hospital, Birmingham, a leading quaternary care hospital in the UK, which has the largest transplant program in Europe. Dr. Jurawan has since migrated to Barbados and has worked as a consultant nephrologist at the Queen Elizabeth Hospital for the last 3 years. She has specialized in all areas of nephrology, but has special interest in the following areas: renal transplantation, chronic kidney disease, KEEP, which is Kidney Early Evaluation Program in Barbados, pregnancy in chronic kidney disease and transplantation, renal vascular access, and rare diseases. Her research interests include chronic kidney disease and acute kidney injury, with a paper published in an international journal on mortality with acute kidney injury. Dr. Jurawan will be presenting peritoneal dialysis. Over to you, Dr. Jurawan.
Thank you. Pleasant morning to everyone. Before I start, I just want to make sure that I'm doing this correctly. So it says share screen, so I'm going to press yes. Everyone can see it?
Yes, we can.
Okay, great. So pleasant good morning to distinguished guests, colleagues. I'd like to say a very special good morning to Dr. Roberts, who is and still remains my mentor and has inspired me to my career in renal transplantation, really. And I'd like to thank Dr. Hasina Mohammed and all the organizers of this meeting and for allowing me the opportunity to speak. It was very good yesterday to sit and learn about the developments in renal transplantation in Trinidad after I left home. And I'm quite proud. And I know that the transplant, Dr. Roberts' transplant legacy, based on all the speakers that I've heard yesterday, you know, it is in very good hands. So this morning, I'm going to speak to you about peritoneal dialysis, but since this is a transplant meeting, I thought we would look at whether peritoneal dialysis as a mode of renal replacement therapy is better versus hemodialysis before a transplant. We know that the gold standard for renal replacement therapy is transplantation. So just a brief outline. And why am I not moving? Okay, so we're going to look at peritoneal dialysis, and this is basically for a very brief introduction, just for the trainees who may be with us. And we'll look at the peritoneal dialysis program in Barbados. We'll also look at transplant outcomes in peritoneal dialysis versus hemodialysis patients. So this is just a slide showing peritoneal dialysis. Basically, this is a form of renal replacement therapy where the peritoneal membrane acts as the filter, if you will. And what it involves is the insertion of a catheter into the abdominal cavity. And this catheter is attached to these bags containing the dialysis solution, which basically is the hyposmolar glucose solution, or you can use the icodextrin. And the fluid is introduced into the abdominal cavity. It stays in there for a couple of hours, and then it is drained out, and that's how the dialysis proceeds. If this happens intermittently throughout the day, let's say a dwell time of 4 to 6 hours, then it's called continuous ambulatory peritoneal dialysis. Whereas if it happens in the night with the machine, it's called automated peritoneal dialysis, and that's the type that we do more of in Barbados, and I'm sure all over the globe. So looking at the modality preference, so what I'm going to say is that I think peritoneal dialysis is an excellent modality, but it's severely underutilized. And we're going to talk about that a little later on. But if we look at the advantages and disadvantages compared to the two types of modalities, with hemodialysis, the patient is taken care of. So they come to their dialysis center and the medical staff takes care of them. Whereas with peritoneal dialysis, it is an independent process. Yes, we train you up how to do your dialysis, but we empower you to take responsibility for your health. And that is very, very important. With hemodialysis, there's a rigid schedule, and I find for a lot of patients, there's a difficulty to work and travel. If you think about it, these patients spend a lot of their time either coming to dialysis, waiting for dialysis, getting the transport home. So it's quite difficult to lead a normal life, especially for the young, productive members of society. Whereas with peritoneal dialysis, your time is your own. Your schedule is flexible, it's easier to work and travel. Therefore, I find when compared with hemodialysis patients, peritoneal dialysis patients have a better quality of life. With the home consideration for hemodialysis, there's none. However, with peritoneal dialysis, we have to ensure that the environment is very clean, there is storage space, and also, of course, in the developing world, if there's running water and electricity. Again, with hemodialysis, there's the post-dialysis fatigue, which can last for up to 8 hours, but there's nothing like that with peritoneal dialysis. I'm going to leave this for a little later in my next slide because it's very important. And we do know that hemodialysis, out of the two options, is more expensive. So it's hemodialysis the most expensive, then peritoneal dialysis, then of course renal transplantation, which is the gold standard, and it is the most cost effective. So regarding hemodialysis, we have, you need venous access, so they're needle sticks, whereas with peritoneal dialysis, it's bloodless. Of course, with the both, there will be access complications. For hemodialysis, that involves line sepsis, bacteremia, infective endocarditis. You can develop a Steele syndrome based on the arteriovenous fistula, and oftentimes it needs to be tied off. And of course, there's central venous stenosis, which we'll come back to later on. With peritoneal dialysis, the complications consist again of sepsis, peritonitis, you can have a fluid leak, you can have catheter malfunction, and you can have hernia development. Now, I said earlier that peritoneal dialysis was underutilized, and I think it is, and I think a lot of the reason for it is that we as nephrologists probably don't push it enough, because a lot of my patients in my low clearance clinic, when I speak to them about the two modalities, instantly when they hear that they have to do this on their own, they get scared. And I think it's our job to reassure them that you are going to do this, we are going to train you up how to do it, but we're not throwing you into the deep end. We are there in Barbados, there's a 24-hour on-call system. The nurses are excellent, and any problems they have, they can come to hospital. So that's the first thing. The second thing is that there are a lot of misconceptions. A lot of people think that your survival is actually worse on peritoneal dialysis, and also the infection rate is actually higher on peritoneal dialysis, which are all myths. So if we look at some of the evidence, important thing I wanted to speak about, which is the preservation of your residual renal function. Now, this is vitally important because studies have shown that the residual renal function is an important, favorable, and prognostic indicator of reduced morbidity, mortality, and a higher quality of life in both PD and HD. Studies have shown in the Canada, United States PD group trial, the Netherlands cooperative study on the adequacy of dialysis, and large cohort trials have addressed the importance of this residual renal function. The survival benefit that was shown was attributed to the renal clearance rather than the dialysis clearance. So the benefits of this residual renal function have been related to greater volume removal, protein-bound solute clearance, middle molecule clearance, and reduced inflammation. What is important is that despite the advances with hemodialysis, better machines, better dialyzers, when compared to peritoneal dialysis, you still have that benefit of maintaining your residual renal function, simply because the peritoneal dialysis is a gentler therapy. You have less of these rapid fluid shifts over short spaces of time, and that maintains your residual renal function, which leads to better survival. So going back to the PD outcomes, if we look at this study by Malhotra et al., you can see that from 1996 to 2004, the mortality is actually better with peritoneal dialysis, with these hazard ratios improving. Looking at a more recent study coming out of Korea, we can see here with the mortality trends, the hemodialysis, the black line, and the peritoneal dialysis, the red line. You can see from 2005 that the trend is for both modalities that the mortality is better. However, the peritoneal dialysis is actually a lot better when compared to the hemodialysis. And there are a lot of causes, for this. One, the infection rates are actually lower, and there have been advances in the technology of the peritoneal dialysis. We now have the Y system, the double bag system, the lower lock system. You can use prophylactic antibiotics against the staphylococcal infections. So looking at peritoneal dialysis in Barbados. So this program was started approximately 13 years ago by Dr. Anil Mohammed. And I'm just going to look at the snapshot of the last 5 years. So if you can look at what's happening here, you can notice the trend that the peritoneal dialysis population is growing in Barbados. We've had a little decline this year, unfortunately, and of course that's because of COVID. So what's important here is that in Barbados, as with the rest of the Caribbean, we're seeing the explosion of chronic kidney disease and end-stage renal disease, and we simply do not have the resources to offer hemodialysis to everyone. A third of my patients, unfortunately, are still getting twice-weekly dialysis, which I think is just rubbish, but we can't do anything else. So what my colleague and I really push for our patients is the peritoneal dialysis. So this is why we have good numbers, and hopefully it is going to improve. Looking at the rates of peritonitis between 2015 to 2020, unfortunately, there is an increasing trend. I'd like to attribute this to the increase in numbers also, but obviously we have to go back and do some audits and see exactly what is happening. And I suspect a lot of it has to do with patient technique. Looking at the number of patients converted to hemodialysis, so there was an increased trend, unfortunately, last year. And a lot of it had to do with catheter malfunction and, of course, peritonitis, repeated peritonitis, and also with organisms that required removal of the catheter, like your Pseudomonas or your fungal infections. So apologies for this small writing, but this is a snapshot of our patients last year, and we're just looking at the causes of end-stage renal disease, and the majority was hypertension by itself, and of course this is diabetes, 28%. This is a mix of diabetes and hypertension, and the 3%, our population was retroviral disease, polycystic kidney disease, and lupus nephritis. So I'm just going to show you a picture of our lovely nurses, and this is the key to any successful peritoneal dialysis program. Our nurses are diligent, they're hardworking, and they're there for the patients. They explain everything to the patients, and the patients are reassured that they can contact them at any time. They are the major interface with the patients. Here we have them when we introduced the Claria home source machines approximately a year or two ago. And this has helped again with patient reassurance, because now we are able to actually monitor patients because of this technology, and we can see what's happening with their dialysis via the computer rather than them coming into clinic with their little notebook showing us all the parameters. So this was a very good innovation. So now we're going to look at the choice of modality, pre-transplantation. So the impact of pre-transplant dialysis on both short and long-term post-transplant outcomes remain controversial. The first meta-analysis was actually conducted in 1993 by Winchester et al., and there has not been an update for almost 20 years. What I would tell you is that when we're looking at the data, just keep these caveats in mind. All the data, unfortunately, is observational. There's no randomized control trial, and I don't think there ever will be. I think the last randomized control trial looking at hemodialysis and peritoneal dialysis was done in Scandinavia. It was a small number, and it did not include anything about transplantation. So having said that, the selection bias cannot be definitely excluded in these retrospective cohort studies. Heterogeneity is an important factor owing to the diversity in the baseline characteristics which we cannot correct for. And of course, confounding factors could not be controlled or matched. So let's look at the recent meta-analysis. Sticking again. Okay, so we're going to look at this meta-analysis by Tang et al. And they basically, after strict screening, they looked at 12 studies from the PubMed, Embase, and the Cochrane databases. And their outcomes, they looked at short-term outcomes and long-term outcomes post-transplant. They looked at delayed graft function, which we know is the need for dialysis within 7 days of transplantation, and they looked at acute rejection. For long-term outcomes, they looked at the 5-year patient survival rate and the graft survival rate. So if we look at the risk of delayed graft function and acute rejection, we can see here that the risk of the odds ratio for delayed graft function appears to be better with peritoneal dialysis rather than with hemodialysis, with an odds ratio of 0.67%. And the heterogeneity rate was moderate. With acute rejection, it's shown that peritoneal dialysis again appears to be beneficial with an odds ratio of 0.96. And there was no heterogeneity shown here, but this was not statistically significant. So looking at the 5-year patient survival rate, again, it shows that the peritoneal dialysis patients, the 5-year survival rate was actually a little better. But this was significant, but there was a high heterogeneity rate, things that we can't account for. Looking at the 5-year graft survival, what is shown is that there is really no difference with a hazard ratio of 0.92. Again, a very high rate of heterogeneity. So looking at another study by Deepika Jain et al., they looked at some short-term outcomes, again, delayed graft function. They also looked at renal vein thrombosis, the risk of infection, NODAT, and which is new onset diabetes after transplantation. And they also looked at some long-term outcomes, such as patient survival and graft survival. In the interest of time, I'm not going to go into the long-term outcomes because it basically showed what the meta-analysis showed. Some studies said yes, some studies said no, but we are going to look at delayed graft function again, which again favors peritoneal dialysis in a lot of the studies. And again, I think the reason for that is that when we go back to the preserved residual renal function, it's very important. Less fluid shift, especially before transplantation, a better fluid status can lead to better outcomes, especially with delayed graft function. If we look at renal vein thrombosis, this surprised me because it was actually higher in the peritoneal dialysis cohort as opposed to the hemodialysis population. Looking at the risk of infection, we do know that the immunosuppression used for transplantation increases your risk of infection. So I've looked at 3 studies and they have shown that there's a slightly higher risk of developing post-transplant peritonitis, especially with those that had delayed graft function. And this was a little higher as compared to HD. They also found urinary tract infections in PD patients, but one study by Lin et al. Showed that there was a higher risk of new onset tuberculosis and chronic hep C in patients 90 days post-transplant for those treated with HD. Looking at new onset diabetes, 3 studies were looked at. One didn't show any impact of the dialysis modality. The other 2 did find an increased risk with peritoneal dialysis. And of course, confounding factors, we know that factors associated with the development of new onset diabetes after transplantation are the presence of pre-diabetes, the immunosuppression, particularly the tacrolimus, improved appetite, and of course the weight gain. So to conclude, did I convince anyone that peritoneal dialysis is a better mode of replacement when considering transplantation? Not sure, haven't really convinced myself. It's difficult to answer without a large numbered randomized controlled trial. However, what I would say, and my take-home message to you all is, the education regarding modality choices must be multifaceted and patient-centered. It should include the impact on renal transplantation, short and long-term outcomes, in addition to the impact on lifestyle. It should also be based on what you think is the best option for your patients and in your particular setting. And the reason I'm saying that is that because I know that in Barbados, I can't offer everyone hemodialysis, and I'm still having patients on twice-weekly dialysis. If I have a fairly young patient from their 20s, let's say to their 40s, early 50s, my goal is to get this patient to transplantation. So in the interim, I usually try to start with peritoneal dialysis. And again, that's to preserve their residual renal function, to preserve their quality of life, to leave them empowered, leave them into a near normal life. You know, they're in the workforce or they're still at school, and until I can get them to a transplant. Now, one important consideration is also venous access. What I tend to do is, if a patient is young and I know they are going to be on dialysis for the rest of their life, if they don't get a transplant, then I always prefer to start with peritoneal dialysis because that leaves the veins alone. Currently, I have about 3 patients in their 30s and 40s with end-stage vascular access. One I've had to convert to PD, the other one has failed PD, and the other one, again, he has failed PD. And when this access runs out, I don't know what I'm going to do with them. So I'd just like to leave you with a little case, and this again is going to illustrate what Dr. Lynch so eloquently said yesterday about renal transplantation is the best option. This is a case of when I met her, she was 11, but she developed end-stage renal disease at the age of 10 years. And she required emergency hemodialysis, and then she was converted to peritoneal dialysis. The cause of her end stage was congenital kidney disease. She had a single shrunken right kidney. So this little girl went on to peritoneal dialysis, and she had repeated episodes of peritonitis. She had to be converted briefly to hemodialysis and then returned to peritoneal dialysis after we ensured that there was nothing structural. It turned out to be the technique. But what had happened? Of the new Premier League season takes place at Swellington. Hello? Can you all hear me?
Yes, we are.
Oh, okay. I was just hearing someone speaking. So this little girl, because of her repeated episodes of peritonitis, it was difficult to control her fluid. And as we know, with all end-stage renal patients, the major mortality and morbidity is cardiovascular disease. And with these fluid shifts, her heart became affected. She went on to develop a dilated cardiomyopathy. Her ejection fraction fell to, well, 20% when we actually did the echocardiogram, and her blood pressure fell. So we were in a situation where we couldn't control the fluid, and also we couldn't offer hemodialysis because her blood pressure was too low. So she was maintained on hemodialysis. She started seeing the pediatric cardiologist, and along with the medical treatment and with very rigid attention to her dialysis prescription, we finally got her volume status under control. So I would see her very often and make sure that, you know, everything with the prescription was tip-top, her parameters were good, and we finally got her ejection fraction up to about 35%, which is where we decided that we would bite the bullet and offer her a renal transplant. Her mom was the live donor. And this is a picture of her, and I've labeled it, the proof is in the pudding, because this is her on the first day of transplant. This is mom, of course, looking like a supermodel after donating a kidney. And this is her last year, and this child is a lot better. She's now 13. Now she can go to school without being short of breath. she's actually dancing in church, and her ejection fraction has now improved from what 37%, now it's 48%. So this for sure shows that renal transplantation is the best option. So I'm going to leave you with that. Well, actually, I'm going to leave you with my favorite beach, and I will take any questions at the end. Thank you.
Thank you, Dr. Jeroen. Our next feature is entitled Trinidad and Tobago Transplantation Experience and Updates. This will be presented by Dr. Malcolm Samuel. Dr. Samuel has been a consultant general and renal transplant surgeon with the National Organ Transplant Unit since 2008. He is also the acting clinical director of the transplant unit. His training includes general surgery training in Barbados, Jamaica, and the United Kingdom between 1990 to 1997. Also, renal transplant fellowship training in the UK from 2003 to 2006, and then laparoscopic donor nephrectomy training fellowship in the UK 2010 to 2011. He initiated laparoscopic hand-assisted donor nephrectomy for all live donor transplants since November 2011. Dr. Samuel?
Hi. Good morning. Everyone hearing me?
Yes, we are. Go ahead.
Trying to get my, I think I shared my screen. Okay, I'm not sure what's happening here. I'm a little technically challenged, I must admit. I'm not seeing my presentation coming up. Sorry. Anything coming up? Hello?
No, not yet.
I see now. I did.
We apologize for the technical difficulties. We're just asking for 5 minutes to sort out Dr. Samuel's presentation.
In the meantime, we just want to share some information about the Trinidad and Tobago Medical Association. As some of you may know, we have 5 branches. So we have the Tobago branch, North branch, South branch, the Eastern branch, and Central branch. Each branch within their, okay, I see we're back up online and we're ready.
Yeah, it's up. What? Hasina?
Dr. Samuel? Hello?
Hi.
Hi, you can go ahead and present and I will move the slides for you when you're ready.
Oh, because I just realized I wasn't able to move them.
Yeah, I will move your slides for you. Go ahead and present, Dr. Samuel. Thank you.
Okay, thanks. Right, good morning, everyone. Apologies for my technology challenge here. First time I'm presenting on Zoom. So I'm just gonna give a quick run through as to what's been happening with NO2. Next slide, Hasina. So we're just gonna give a quick background how we were set up, some of our statistics, some of our achievements, challenges, and what we would like to do further going forward. This is our 15th year, actually. And we want to build on what we have achieved so far. Next. So, as has been mentioned by previous individuals, we have had transplantation in Trinidad since 1988. Mr. Nabi Khan did well for 30 years and is now back on dialysis. There were a couple of periods. There was a period between 1989 and 2005 when 36 live donors were done. Program wasn't organized. No regulations or legislation was in place. Next. So there were 2 eras, 1988 to 91. When 6 were done, then there was a tail off. Next. Then there was a second phase between 94 and 2005, mainly private. Again, it was curtailed because of the lack of legislation in place. During this period, next, there was a phase where patients went to India and Pakistan for transplantation. I think the number was about 54 patients. And unfortunately, that was marked by lots of morbidity and mortality for these patients. So next. Yep, that was the first. Next, journey 2, right? So we can see, next, mortality and numbers reflected an obvious demand for transplantation and some level of desperation. Next. So how do you build a sustainable organ transplant program? So what we have found is we have 4 pillars. We need laws and regulations, which the Human Tissue Act of 2000 and the regulations of 2004 established the legal framework for organ transplantation and blood transfusion. NO2 is the transplant organization through which transplantation can occur. Financial support from the ministry, and NO2 is presently an arm of the ministry, but we are hopefully going to transition to NCRHA, which would allow for a little more efficiency in terms of our backup services, finance, etc., etc. And then obviously you institute the transplant programs, kidney and corneas. Next. So we began in January 2006 as an arm of the Ministry of Health. We are established and based at Eric Williams. We were created to perform renal and corneal transplants. The corneal transplants and presently, unfortunately, have gone by the wayside for multiple reasons and with no lack of trying by Dr. Roberts while she was here. Actually, so initially the unit was actually mainly a coordinating unit. The first case was done by surgeons in Trinidad who were invited who did the first case, but complications developed, and the subsequent 2 years involved mentoring of a local team, to hire a surgeon who started in the middle of 2000 and who started in the first quarter of 2006. And we had 2 senior transplant surgeons from the UK who would rotate down, and we would do surgery every 3 to 4 months with a week of transplants. Next. So again, our legal basis. And one of the important things was that the concept of brain death was established and is now part of the legislative framework. It facilitated deceased donor program and prohibits organ trading. Next. We started first with our live donor program, as mentioned before. We did 8 in that year, and 4 of them are still going and doing very well. At present, we have 6 pairs being worked up for surgery, which we hope we will be able to do for these 6 pairs by December. Our deceased donor program, which was launched in 2007, is an opt-in scheme. Bridget did mention that we should probably think of an opt-out scheme. I am not, while that will be ideal, I don't think culturally and as a people we are ready for an opt-out scheme. In terms of our deceased donor list, we have 1938 registered card-carrying donors. We have 10 active patients on the waiting list with a further 15 to 20 being worked up. Next. One of our important committees is an ethics committee, which was established under the Human Tissue Act, and it ensures that there's no coercion, no payment, organ trading, and we ensure that the donor fully understands the donation process. The members are appointed from, we have representation from nurses, patient advocate, the interreligious organization, psychiatry, and a legal representative. So they screen certain categories of live donor pairs. Our social workers prepare the psychosocial assessments for the committee. No staff member of ITNO2 is present during the deliberation, so it's all independent. And all pairs who are not first generation genetically related are screened, including husband and wife, which, while they are related, are not genetically related. So the ones who escape are children, parents, brothers, sisters, siblings. Next. We have also developed a number of collaborations over the years. The two most important ones are with the Transplant Links community from Birmingham. Their main function has been to assist us with our pediatric transplants since 2008. We have done 10. We have one patient awaiting transplant, which we hope we can do by the end of this year. She's ready and waiting, just some issues with her father. And we have a strong relationship with DTI, with Maria Paula and her group. Have been training and supporting us and promoting deceased donation since 2010. They have been very invaluable in terms of getting our activity to the level at which it's at. Next. Our present staff, transplant surgeon, myself, Dr. Lynch, we've got 2 recipient coordinators who are, and each patient, each post-transplant recipient has a dedicated coordinator. We have a donor coordinator, 2 social workers, and our administrative staff is headed by our business kind of office manager with 2 OJTs. We incorporate 2 surgeons from Eric Williams on surgery days. Next. So what have we done? We've heard some numbers. So yes, we have done a total of 189, live donor 147 or 77%. We have been fortunate in that we have been able to resume activity post the extreme lockdown for COVID. We have done one 3 weeks ago. We have another one scheduled for the end of this month. So we have done 3 since COVID. Our deceased donors, 42, 23%. Within the program, we have done 2 second transplants, and we have at least 2 other persons whose kidneys have failed and who are interested. So we are pressing on with those. Of our live donors, 69 have been male, 56 have been female. I think I have that percentage wrong. Deceased donors, there's a predominance of male, as you can see. Recipients, 112 males, 77 females, both live and deceased donors. Next. We're presently following up 128 patients. 25 patients' kidneys have failed and are now back on dialysis. We have had 36 deaths within the course of the program. For various reasons, we have had 4 deaths within the first 30 days for cardiac and related issues. We've had 3 deaths from anastomotic bleeding and post-operative bleeding. 2 were live donors. 1 was a deceased donor. 1 CMV sepsis, and the other causes have been varied: cardiac, sepsis, one of our pediatric cases unfortunately died in a car smash-up, which claimed members of his family. He has actually gone back on dialysis and was going home from a dialysis session. Next. In terms of procedures, initially we started with the open nephrectomy. We did 70 up until 2011. We had a visiting surgeon from Spain who did 5 laparoscopic surgeries for us in 2012 and 2013, including our 2 right nephrectomies. Predominantly, we do left nephrectomies. And I have introduced hand-assisted laparoscopic donor nephrectomy, which is our standard donor technique since 2011. We have done 72 in all. 3 were done by the TLC team prior to my training, and since November 2011, I have done 69 of these hand-assisted donor nephrectomies. Next. We have a lot of experience and team. We have a core team, myself, Dr. Hananam, Dr. Valeron. So we have been able to tackle technically challenging double arteries. We've had 2 patients with bifid or double ureters. Last one, actually, our last one 3 weeks ago. That's went well. No surgical issues. We've done 2 right kidneys with assistance from our colleagues from Spain. Next. Some complications. First of all, we've had no donor mortality. Donor death will shut your program down. We've had 3 open conversions to open for uncontrollable bleeding, 2 venous, 1 arterial. We had 1 re-exploration for a patient who unfortunately was given 60 milligrams of Clexane instead of 20 milligrams for DVT prophylaxis. HB continued to fall and we had to re-explore. Generalized ooze was noted. The Clexane obviously had been stopped and she did well post re-exploration. 1 patient developed an abscess in the left renal bed. Not quite sure how that happened, but it was well walled off from the rest of her peritoneal cavity and it was drained by interventional radiology and resolved successfully. We've had 2 incisional hernias, 1 in an open flank wound and 1 in a unassisted port side. But this gentleman was a man who was a smoker before and started smoking immediately after surgery, despite our advice. He has been repaired, and both of them have been repaired successfully. Next. None of our donors, as far as we are aware, has developed end-stage or chronic renal disease, which obviously is one of the things we screen for. Well, I shouldn't say screen, but hopefully in determining or choosing the donor, we try to make sure that such an individual is at very low risk of developing this problem. We have had 5 of our donors, female donors, subsequent pregnancies, including 1 pair of twins. Unfortunately, 1 of our males has developed prostate cancer, but that's stable under urology care. Next. Some of our recipient complications, we had an acute rejection in the first year, but she has been successfully retransplanted. We had a primary non-function. Again, there is always a low rate. This was a live donor. He unfortunately fell victim to a primary non-function, is back on dialysis, and is exploring the option of a second transplant. We had 4 delayed graft function. We've had 1 patient with post-transplant lymphoproliferative disease 2 years ago, 3 years post-transplant, and he has been successfully treated with rituximab. We had 1 patient, quite severe adhesive bowel obstruction, not related to our recipient surgery. He had to have multiple laparotomies, had a stroke in hospital, and unfortunately, he died some months after transplant, secondary to his stroke and his abdominal issues. We had a very interesting young man who had an external iliac artery dissection. Immediately post-op, kidney function went off, and we rushed him back into the OR and successfully reanastomosed the kidney and dealt with his external iliac artery dissection. And I'm pleased to say 4 years on, he's doing quite well. Next. Some more complications. We've had 3 ureteric stenoses. The very first patient done in 2006, he developed ureteric issues, and there was some problem with having it dealt with locally, and our visiting surgeon, first visiting surgeon we had, reimplanted his ureter successfully, and he has gone on to do very well since then. We had a second one in 2012, and he had a balloon dilatation per urethra and has done very well since then. Our third presented within the last 4 weeks. A mid-ureteric stricture narrowing with hydronephrosis in the transplant kidney. A bit unusual because she is 5 years post-surgery. Right now she has a stent nephrostomy, and urology are going, and interventional radiology are going to attempt to stent her either from below or above, and then hopefully we can dilate her and remove the nephrostomy. We've had 4 ureteric leaks, all treated conservatively, and they subsequently did well. Next. Just some demographics here of our first 100 transplants. As you can see, percentage male, 57, female, 43, ethnic, and donor living and deceased. Next. Again, this is for age distribution for our first 100 transplants. Next. And some relationships in terms of our live donors, and spousal, non-spousal, child to parent, parent to child, sibling. In the sibling group, we have had the privilege of doing 99.9% identical twin, brother to brother. And he is doing very well on minimal, Sean might correct me, I think he's only on a slow dose of prednisolone. So,
he's on none, he's on no immunosuppression.
Okay, great. So, but he's, we did his genetic studies, and they came back as 99.9% identical. So that he has done very well. Next. So as we approach our 200 transplant and our 15th year, as I mentioned before, 50% of our patients from 2006 are alive and well. Our 1-year graft survival is about 96%. We are going to be doing full analysis of our survival statistics at the end of our 15th year. And I was hoping to have reached 200 this year, but COVID has put a dent in that plan. One of our successes has been a female recipient, and I dare say this might be the first in the English-speaking Caribbean who has had a successful pregnancy and now has a 2-year-old son. She, in fact, is one of our recipient coordinators, and her enthusiasm for her patients knows no bounds. We've had 7 male recipients who are fathered children post-transplant, and well, not beating my chest, but we have a well-established and functional transplant program offering a viable alternative to hemodialysis. So Nerissa, we'll happily take your patients and transplant them for you and send them back to you. Next. Some of our challenges. As Bridget mentioned in her talk yesterday, our budget, and I'm excluding drugs costs because drug costs would come under central cost, is 1% of that for dialysis. So we are severely hamstrung in some of the things that we can do and we would like to do, in terms of, as a surgeon, we have some issues getting instruments, equipment. I've recently been able to get some new instruments after 15 years. Unfortunately, what happened with our previous instruments is that the rest of the general surgeons would use our instruments. So obviously these things would get, they will become non-functional over a period of time. The laparoscopic stack is no good. And you know, things like in terms of post-op care, we would like infusion pumps for ourselves and so on, but we can't get these things. So yeah, bureaucracy, unfortunately, again, as mentioned in previous talks by Sean and Bridget and Dave, reagent access and sourcing for the lab is a bugbear. It is a headache. The delays in the bureaucracy in terms of ordering, paying, receiving, it's just a nightmare. It's out of our hands, unfortunately. We don't control it. We have no say in it. I hope that when we transfer to the NCRHA, that pipeline will be a little shorter so we can, you know, press the right buttons and get things done in a much faster, much more, you know, efficient manner. We have had issues over the years with ensuring adequate supplies of immunosuppression drugs. There are times when we don't have, patients have had to buy drugs, some, you know, at times when there have been shortages in the pharmacy. That is an issue which has to be seriously looked at, because sometimes I get the impression the ministry or NIPDEC doesn't realize that each transplant we do means that they have to have more drugs available. We need improvement in the immunology lab services. We need to upgrade our cross-match. Right now we do a cell-based cross-match. While it's adequate, ideally, we should go to a flow cross-match system. We need to be able to do antibody identification, especially now that there are going to be people who want to come back for second transplants. And we need to be able to do viral load counts for CMV and BK viruses when we have patients who we suspect have these issues post-transplant. Right now they have to pay a couple $1,000s to have their viral load done, and it does take about 7 to 10 days. So you may, while you may suspect a patient has CMV or BK issues, we often have to treat them presumptively until we get back their viral load. And then in terms of following them up, it can be a little bit difficult. Getting a transplant experienced immunologist, I think, would be an asset. And it would be great to have a renal pathologist in-house to be able to diagnose our post-transplant biopsies. I know Sean has an issue with some of the reports that we get back, but it is very critical if we are going to be doing more to be able to have accurate diagnosis of our post-transplant recipient biopsies. Next. We are getting overrun with paperwork. As you know, we're following 128 people plus the donors, etc., etc. Our space is small. We really need to get a transplant-specific IT system for donor and recipient management. We really have to get that. I have made a few efforts to try to do that, but we really need a program specifically designed for this. One of the things we need to do is also to mount a comprehensive education program. We need to sensitize the public, attract more potential donors, both deceased donor, potential donors, and also for individuals who have, you know, who are approached by family or friends to be able to understand and come forward in terms of being a donor for their family or friends. We need to upgrade our staffing. We need to look at succession planning. And hopefully this will occur when we change over to the RHA. Next. Future. I want us to get to our 200. I was hoping we would have reached there this year, but COVID has put paid to that. Hopefully by early 2021. if Bridget gets me a few deceased donors this year, and we may get there by the end of this year, which would be great, because it would coincide with the end of our 15th year. We are also going to be looking at doing paired exchanges with suitable live donor pairs, because often we do have somebody who might be suitable, but they are incompatible in terms of the blood group. I think we can increase our numbers to 25 to 30 cases per year. And I hope that we are able to do that sooner rather than later. We need to have, as I mentioned before, nationwide information and education. We need to increase our deceased donor registry numbers. I would like to get us to in the thousands, not 1938 as we are at the moment. As I mentioned, we need an electronic patient management system. And we also need to discuss with our colleagues, liver, pancreas, lung, heart, other organ transplants. Bridget mentioned skin tissue banking. I've also spoken to orthopedic surgeons in terms of cartilage and so on for cartilage so that they can use for knee reconstructions and joint reconstructions, and audit and research our publications. Next. And finally, our pillars are important to start, but the intangibles are what are required to sustain and develop it. These are the intangibles, and we need to continuously monitor and reevaluate our program. Next, just to show you a picture, this is what we want to achieve as a surgeon, nice healthy kidney ready for implantation. Thank you very much.
Thank you for the update, Dr. Samuel. This is a gentle reminder to everyone to write down your questions and the speakers to which they are addressed for our question and answer session at the end. Also to our speakers, we are a little over time, so we're going to have 2 bells, 5 minutes prior to the end of the time allotted, and then at the end of the time. Okay, so we move on quickly. Our next segment is entitled Strategy and Plan of Action on Donation and Equitable Access to Organ, Tissue, and Cell Transplants. This will be presented by Dr. Paul Edwards. Dr. Paul Edwards, MPH, Epidemiology, has over 18 years of experience in health system analysis, health policy development, public health planning, and epidemiology, gained from a career in Belize as a director of Epidemiology Unit and the National AIDS Program. He has been acting Deputy Director of Health Services, a regional manager, as well as advisor for the HIV and STI surveillance at the PAHO and HIV Caribbean Office, and PAHO and WHO advisor for health systems and services in Barbados, Guyana, and now Trinidad and Tobago. Currently, he's engaged at the PAHO WHO Trinidad and Tobago, Aruba, Curacao, St. Martin, Bonaire, St. Eustatius, and Saba Country Office as the advisor, health systems and services, where he is responsible for providing technical cooperation, principally to the Ministry of Health in the following areas: leadership and governance, human resources in health, health financing, health services, medical products and technologies, and strategic information. He has written various scholarly articles on HIV and health systems and services and other public health subjects. He is committed to PAHO's mission to work with member states to promote equity in health and improve the quality of life for the people of the Americas. Dr. Edwards.
Pleasant good morning. Thank you very much to the Trinidad and Tobago Medical Association North Branch on this auspicious occasion of the second Caribbean Organ Donation and Transplantation Summit. I know Dr. Wheeler, my PAHO WHO representative, was on yesterday, and she gave some brief remarks. I also am aware that some of the colleagues who are presently on, like Dr. Kishore Prasad from Guyana, was part of the 19th meeting of the Ibero-American Network Council of Donation and Transplantation meeting held in Cuba last November. There were participants or representatives or national coordinators or program heads from Antigua and Barbuda, Bahamas, Barbados, Jamaica, and as I said, Guyana. So what I want to do is today share very quickly what is PAHO's strategy and regional plan of action for donation and equitable access to transplantation of organs, tissue, and cells 2019-2030. I want to say thanks to Dr. Mauricio Beltran Duran. Many of you others from the other Caribbean countries are aware that he's the regional advisor for blood and transplantation services. So he has graciously provided me with these sets of slides. I've done a little bit of tweaking and I'm here to present this with you today. So the summary of this presentation includes what is some of the Caribbean status of donation and transplantation. And from the very onset, I want to apologize because it is certainly not the most recent data, and therefore I do not want to embarrass myself and not recognize the work that you have accomplished in the years thereafter, namely 2019 and up to date 2020. I just saw an impressive presentation done by Dr. Samuel just now. I'll also speak a little bit to the strategy and the plan of action, speak about the indicators that do exist, and some of the recommendations from the Cuba meeting held in 2019. Caribbean statistics. What can we say overall? We're highly impacted. There's a high prevalence and incidence as it relates to NCDs and therefore chronic kidney disease. When we look at the prevalence of chronic kidney disease in Jamaica, 327 per million population. I'm trying to recall, Jamaica has almost 3 million individuals. So if we multiply that by 3, it's a little less than 1,000 individuals per year. In St. Kitts and Nevis, more recent data, 4.7% as it relates to population prevalence related to chronic kidney disease. Hypertension is prevalent in Jamaica, Barbados, British Virgin Islands, and I would want to say across the Caribbean. Likewise, diabetes, although some of these countries are highlighted here. We certainly have an NCD burden across our Caribbean. Renal replacement modalities, he makes reference to hemodialysis as the preferred dialysis modality in all of the Caribbean islands. We know that we have to make strong efforts for there to be the strengthening programs as it relates to renal transplantation. All of the large Caribbean islands have dialysis units. They're both private and public. And I recall, I would not say fondly that in one country, there are spaces for 30 individuals for dialysis. And as bad as it may sound, unless somebody dies, then another person falls in line. We have got to do better as a Caribbean region. Certainly, this is not the most updated information that I alluded to, but I think what this slide is pointing out, yes, there are more living donors as compared to deceased donors. Registry is very important from a public health perspective to be able to understand, to obtain data, to disaggregate that data, and then to make evidence-informed decision-making. There are contributions to the registry by Caribbean countries, although endorsed by CARICOM Health Secretariat, but the contributions, we must say, there's space for improvement. What are some of the conclusions as it relates to the current status of transplantation within the Caribbean? Within the last years, there have been advances in some countries regarding donation and transplantation. There are normative legislative frameworks that require harmonization and especially strengthening the roles of the ministries, especially the Ministry of Health. Some countries have universal coverage by their national health system. Most of the donation and transplantation activity takes place in larger countries like Brazil, Argentina, and Mexico. There is a registry called DonorSur that has 13 countries, established in 2016. Highlighted in the presentation before, the need for more training of human resources. Although there are standards and technical guidelines, the degree of implementation in each country is a little bit unknown. And there is information through the registry at DonorSur, and some countries really have their own. There is limited development of transplant activity in the Caribbean. And I think some of these countries are highlighted here, whereby there has been improvement over the years. Jamaica, Antigua and Barbuda, Barbados, Bahamas, Guyana, Trinidad and Tobago. And these are countries who do some reporting as it relates to their activities. However, there's no information of transplant activity in the other Caribbean countries besides those that have been mentioned above. Once again, hypertension and diabetes have high prevalence in the Caribbean and therefore creates the need for renal transplantation. The Caribbean Renal Registry was established in 2006, but there are challenges as it relates to its usage. Challenges as it relates to transplantation. Non-recognition of transplantation as a cost-effective therapeutic alternative in low and middle income countries. So I recall fondly when we were there in Cuba, there was a call for papers to do the cost-benefit analysis. Prejudice and lack of information regarding voluntary donation of organs, tissues, and cells in the community. There are differences in the level of development in donation and transplantation in the region. The persistence of trafficking in human organs, tissue, and cells is still a challenge. Scarce human resources trained in donation and transplantation. Low donation and transplant rates sometimes in living donors. I see that there was a major improvement as it relates to the presentation before, and I'm certain that will become more evident as my colleagues from Barbados and Guyana will present. The issue, which is very important, of lack of funding and financial protection for the donations and transplant activity by the national health system in central country. This is one of the very challenging areas. Information of transplanting activities in the Caribbean countries, I alluded to that, the need for improvement as it relates to reporting and providing information for evidence-informed decision-making. So leading to the strategy, there was a policy framework from the year 2009 established and accepted by the PAHO, when there was a PAHO Council meeting. And at the very heart of that policy framework is to promote equitable access to transplantation services and includes various components, applying the guiding principles on human cell, tissue, and organ transplantation, voluntary donations, eliminating organ trafficking and transplant tourism and avoid economic gains, to improve the safety and efficacy of donation and transplantation, to collaborate in the collection of data, especially on adverse reactions and events related to the practices, safety, quality, efficacy, epidemiology, and ethics of donation and transplantation, and to strengthen national public authorities and their capacities, and to stay actively involved in the Ibero-American Network Council of Donation and Transplantation and other regional entities, including Mercosur and CARICOM. Now, I want to speak specifically to the strategy and plan of action on donation and equitable access to organ, tissue, and cell transplant. This was also at one of PAHO's directing council, held once per year, and being present at this meeting are the ministers of health, alternates, and delegates. We need to have that push, that impetus, that advocacy for ministers of health to attend these meetings when these critical and important topics are being discussed, for them to have the information and therefore to be able to support these critical interventions that are needed to save lives and improve the quality of lives of individuals. So, at the heart of this plan, the primary objective is to promote equitable access, just as before, and there are 4 strategic lines of action. The first being to strengthen health authority, governance, and stewardship in cell, tissue, and organ donation and transplant, especially its oversight function. That normally is the function of the Ministry of Health under the building block of health systems, leadership, and governance. The second one is to increase the availability of organs, tissues, and cells through voluntary, non-remunerated donations. The third being to increase equitable access to organ, tissue, and cell transplants within the health systems. And the fourth being to improve information management, and that was alluded to by the colleague before who spoke of the need for an information system, improve information management, monitoring, surveillance, risk evaluation, and risk management activities related to transplantation. So these are some of the major challenges that I think we, and as well as Dr. Beltran, spoke about as it relates to addressing within our Caribbean, to ensure that we have appropriate legislation within the country to harmonize the advances. How do we better improve and organize our national programs? How do we create that network of donation and transplant services, and also create that network for transplant coordinators? I recall at the meeting before there were challenges with that as it relates to someone guiding and overseeing this process to make it a reality and to ensure that there are improvements. Training programs for human resources, spoken about again, and across all our ministries of health in many of the different departments. So how do we improve the skills and competencies to ensure that there's a quality management system? Quality is very important so as to have more better, positive, and impactful outcomes. Budget. I don't think any of you can speak more than to the fact that there's a need for more financial resources for a national plan for strengthening the donation and transplantation activities, and to highlight and promote voluntary altruistic organ, tissue, and cell donation. So besides having the 4 strategic lines of actions, I think there are 20 different objectives. And this is one of the areas we would like to have countries report. I know what Dr. Beltran has done. He has established the baseline, and the target then entails having all the countries of the Caribbean who are involved in transplantation to be able to report. So what I will do, I will certainly ensure that the organizers of this summit has a copy of the presentation, and then normally the HSS advisor in each of the Caribbean island would reach out to the different coordinators or those who are responsible for transplantation services to be able to get a feedback as it relates to the indicators. So when you look at some of the indicators, I like to highlight the one where the baseline is low. For example, number of countries and territories with an adequate budget to finance a national plan for strengthening donation and transplant activities. I highlighted that because in the previous slide, we knew that that was a major challenge. So how do we engage our national authorities to provide adequate financial resources for a program like this? One of the critical areas would definitely be to conduct that cost-benefit analysis, and in the past, with experience from HIV, make presentations to cabinet and be able to get, hopefully in the future, aligned budget for renal transplantation. Other indicators include, for example, let's look at the one that has baseline 0. So I'm looking at the very challenging ones. 2.1.2, as it relates to the objective to promote organ tissue and cell donation to increase the availability of materials and ensure timely access. The number of countries and territories that increase the number of real donors, people from whom at least one organ has been removed for transplant purposes, by 5% every 2 years. Could be challenging, especially in those programs that are in its embryonic stages, but certainly indicators that we should look towards and we should want to be able to achieve. I want to go to the indicator 3.2.3, number of countries and territories with an adequate number of transplant coordinators, and a training program for the human resources involved in all aspects of acquisition or procurement, donation, and transplantation, taught or endorsed by the regulatory body. I know these are the challenges that do exist at the level of country. One of the questions that I want to ask and to share with you is to ask, how can PAHO provide technical cooperation to help you, to assist you to be able to achieve these objectives? Another critical one here is the number of countries and 4.2.1, number of countries and territories with a biovigilance system aligned with the patient's safety strategy and implemented and coordinated by the competent authority that permits the reporting, recording, surveillance, and management of adverse effects. Very important there to be able to document, report, and then to be able to strategize how to be best reduce those gaps. So as I said, those were 20 indicators in the 4 strategic line. A progress report will be done in 2023. So I'm certain that you will be reached out to through your ministries of health. Another one is projected for 2027, and a final report will be one in 2031. And that helps us to understand what are the gaps, what could possibly be PAHO's technical cooperation in providing support to the countries, and how to be able to celebrate our achievements and accomplishments. Last slide would be as it relates to the meeting held in Cuba. What were some of the recommendations? Develop the National Donation and Transplantation Plan based on the strategy that was previously shared. Promote the development of the sub-regional network of Caribbean countries to strengthen the advancement strategy and the plan of action for organ donation and transplantation. Promote the participation of CARICOM countries in the meeting that was held in Cuba last year. Number 4, develop a proposal for a legislative framework for organ donation and transplantation. 5, strengthen or develop national donation and transplant registries. I recall that one was clearly stated at the meeting as it related to the way forward. 6, procure the entry of organ donation and transplantation data in the Global Observatory of WHO and DonorSur, and also our own Caribbean registry. Advancing the implementation of cost-effectiveness studies of renal transplantation therapies in the region. And finally, strengthen activities to promote voluntary and unpaid donation of organs, tissues, and cells. I stop there for now. As I said initially, I give thanks to Dr. Beltran for providing support and lending some of these slides. Thank you very much.
Thank you very much, Dr. Edwards. Our next feature is entitled An Update on Renal Transplantation in Barbados. And this will be presented by Dr. Margaret O'Shea. Dr. Margaret O'Shea completed her training in general surgery in 2006, graduating from the University of the West Indies with a Doctor of Medicine in general surgery. She did her fellowship training in renal transplantation at the Princess Alexandra Hospital in Brisbane, Australia in 2008. She later returned to Queen Elizabeth Hospital in 2009 as a consultant in general surgery and renal transplant. She was the head of the Department of Surgery between 2013 and 2016. In 2016, she joined the University of the West Indies as a lecturer in surgery. She currently works with the University of the West Indies and Queen Elizabeth Hospital. Over to you, Dr. O'Shea.
Thank you. You can hear me?
Yes, we can.
Yes, we can.
Okay, and you're seeing the screen?
Yes, we are.
Good morning, everyone. Still morning. Thank you for the invitation by Hasina to present to this group today. Anything Caribbean, I love to be a part of. And the presentations yesterday and today were all fantastic. I learned so much. So just to give I guess the title is an update, but there are many of you may not know what has happened in Barbados to this point as far as transplantation goes. So in Barbados, some of you may know we have a small population, 290,000. This varies around tourist season, sometimes going up by 10, sometimes even 30,000 if we're lucky. Unfortunately, this year with COVID, I think we're going to stay around 290, maybe 291 at the most, because we're not getting new tourists. That's very important for our GDP. What do we offer in terms of transplantation? So far, we are only offering living-related kidney transplantation. We also do offer cornea, and as was discussed yesterday, we also import our corneas because we do not have legislation to do organ retrieval. So our corneas are imported, and we have an ophthalmologist who does corneal transplantation. What has our disease burden? Like every other country in the world, rising obesity, overweight. We had the National Healthy Nation study, which shows 60% of Barbadians are overweight or obese. And this is leading to diabetes, hypertension, and a growing rise in end-stage renal disease. And this is, I think, universal. We have a large diabetic population, 20%. And when we look at the over 60, this goes up to 50%. How is this reflected in dialysis? We have, on average, I'm sure this changes year to year. Right now we have about 270 hemodialysis patients, and majority of these receive dialysis at the main hospital, the Queen Elizabeth Hospital, in the artificial kidney unit. But we do have a third-party provider, a man by the name of Dr. Lambert. He is a philanthropist, really, but he has set up two outside dialysis units that are privately run, but the hospital outsources to these units at a pretty decent rate. And so we have patients receiving dialysis there. And we also now have a polyclinic in St. John in one of the rural areas that also dialyzes patients, mostly stable ones. Unfortunately, as Marissa pointed out, we have patients receiving only twice weekly dialysis, which is not ideal. That's the most of them actually. And the remainder receive three times a week. What happens sometimes is that patients will get 2 a week at the hospital, and if they can afford, they will pay for 1 privately. Looking at our rates, the rise of patients coming on to dialysis is going up at least 10 to 12 patients every year. So it's just increasing despite all the efforts by the ministry to combat diabetes and the NCDs. The rates of end-stage renal disease is going up and up. This leads to the increased number in the hemodialysis unit. And again, pointing out the inefficiency with only being able to do twice a week as opposed to 3 times a week. But this is because of resources. And I think this is what Narissa was pointing out has led to a lot of peritoneal dialysis being offered, because we are not adequately dialyzing the patients twice a week, even with the exclusions, even with having to turn back patients with poor heart function, age, we look at as well, anybody over 75, multiple comorbidities, ongoing cancer, poorly controlled diabetes. So even with the exclusions, we are not able to adequately dialyze our patients. Again, Narissa alluded to the peritoneal dialysis program, which is really helping those patients who cannot get adequate dialysis, hemodialysis. And these numbers, as she pointed out, are going up. So how does this relate to costs? And when we look at the cost for hemo, it's about annual cost of, we have to divide by 2 for US, but that's about 55,000 Barbados. And these are the costs that the government bears in terms of, so we look at hemodialysis annually about 17, nearly 18 million Barbados. And 5-year projection, that was from 2018. We anticipated that the government would have to spend about 22 million Barbados dollars in dialysis, dialyzing our patients with end-stage renal disease. I think this was said over and over again. I don't think I have to say it to this group, the benefit of transplantation. Why I highlighted the costs is that unfortunately, all the benefits of reduction in mortality, quality of life, back to work, it's sometimes lost on the powers that be, and we have to go down to numbers. They really mostly understand dollars and how we're going to save them money. So this is why we have to push a lot the cost savings and sort of not push as heavily the mortality and the improvement of the quality of life. So we speak to the ministers, and somebody alluded to having to make these arguments to the ministers. Paul was just talking about that. And I think we try to prove to them the cost effectiveness of renal transplant. I had one minister said that transplant is a Rolls Royce of renal replacement therapy, but it isn't. It's the most cost effective. If you're from Barbados, that's like buying a Suzuki, I would say. And what they get put off by is the upfront costs. So we have estimated our costs, and this is excluding professional fees. This is just the cost to the hospital, because most of our patients, I would say, except for one, all of our patients are done on the national budget. And we estimate the cost. This is like all the tests, operating theater time, staff, our salaries, whatever, at 116,000, say 117,000 Barbados dollars, and we can compare that to the cost of hemodialysis and peritoneal dialysis, and see that the first upfront cost is higher, yes, but when we look at then by 2 years, our patients are on medications only. Of course, we have visits to the hospital to check up on them. So we estimated savings of at least 23,000 per patient by year 2. And what we told them is by over a 10-year period, we could save $157,000 for a transplanted patient compared to dialysis. And when we looked at our current population, if we were able to transplant 50%, we would save the government $2.4 million a year. So this is what we put to our government in terms of the cost savings that they can gain by investing in transplant. And I think this particular administration is finally listening. What is our history? First transplant was done in 1987. But then between 87 and 95, we had 9 transplants. I think as Malcolm was pointing out, some of these were visiting surgeons, visiting nephrologists. We did have a surgeon, Loa Lewis, who I believe is in Montserrat now. He was here during that time. One of our pioneer nephrologists, Professor George Nicholson, since passed away. He would have been involved in this early transplant. Professor L. Waldron would have been one of the surgeons around that time in the early 80s, 90s. In 2009, when I returned from fellowship, we did 3 transplants over this was along with Dr. Emil Mohammed, who's now in Trinidad. We did 3, we had 1 early death, but the graft was functioning. Our longest surviving transplant is 21 years. What really turned things around for us was a partnership with Transplant Links Charity in 2015. I think Malcolm alluded to this charity. They do excellent work between the Caribbean and Ghana, and they're out of Birmingham in the UK. So since partnering with them, we have done 10 successful transplants. One of the transplants was a young child who had been fighting with early onset renal failure, and he died at 18 actually after the transplant. He had developed lymphoma, a post-transplant lymphoma. That was regrettable. Currently, we are still getting, so the Birmingham team, the important thing with them, which I really love because they're sort of teaching us how to fish instead of sort of giving us fish. So the skill transfer is going on. In my training, I would have done mostly the implantation, because the unit I worked on, there was one group who did implantation and one group who did retrieval, even with a live donor. So I didn't get a lot of experience in donor nephrectomies, but I must say, thanks to the team from Birmingham, I have gotten great experience in the donor nephrectomy, and that skill transfer is going on. And the last 4, I was pretty much able to do on my own. So we do have them coming up once, twice a year, but I think once we get off and running on our own, we can look to do this on a more even basis, like maybe even if we can get to do 1 a month, that would be fantastic. The last one was in February, very challenging case. Kudos to the nephrologists. We have 2 very dedicated, optimistic nephrologists, Dr. Jarman being one, Dr. Bell is the other one. This patient developed antibody-mediated rejection, and we actually managed to get plasma exchange for him, and the kidney is now doing well. I think his creatinine is 120 or thereabouts. But that was challenging. That was just before COVID. He did have some respiratory problems, and we were worried he did get COVID despite all the barriers that were going on in the hospital. But he did well. I must say, our nephrologists, you know, I always say nephrologists are very optimistic. Sometimes the patients that come to me for access, I'm like, really? But I must say, you know, they look frail, but our nephrologists never give up. So he's doing well. And then, of course, COVID hit. And COVID really put an end to a lot. I think that has been universal, as was pointed out. But this is I just want to highlight the scar. This is our transplant coordinator, Sanemi. She was concerned with the little bump there. But you see the small scar from the lap down nephrectomy. And this, the patients love this. The fact they can have these tiny scars and be up and discharged by day 2 is really beneficial in terms of encouraging donors. And certainly we use a lot of that for the PR of transplant, to see the donors home and very early on with small scars and very little pain. What do we have in Barbados? We have one surgeon, that's me, we have 2 nephrologists, and we have 1 transplant coordinator who, since this administration came on, recognized the importance of the transplant coordinator. Before this, she was doubling as an AKU nurse, and that was very challenging, but she's now full-time. And we have been given an office and a consultation room. So we also, before, had no infrastructure. We're working out of the PD unit, working out of the AKU offices, and this was not ideal. So we have a dedicated space, and we are very grateful. What are our challenges? Limited living donors. I just highlighted the diabetes population. Diabetes population is high. And when we have patients who are coming onto the program with diabetes, you know, the family risk is there, and we're very concerned about taking, as Dr. Lynch was saying, there's no benefit to donation. So we have to make sure the donors are in tip-top shape, and we don't want them developing any renal problems going forward. So this card limits the pool because of the cause of our end-stage renal disease. But we still have a lot of young patients that, you know, I do access as well. And when I see these young people, you know, they really need a kidney, and I really hope we can get the brain death legislation going for these patients who don't have any donors. We have an ethics committee established in the absence of the lack of, I'm hearing somebody talking. In the absence of the lack of the legislation at the moment, we do have a robust ethics committee that vets all the pairs. Staff is another challenge, and funding. So how would we address the limited donors? Raising awareness. So we're out there in the public. Oh, this is a study I just wanted to highlight about the reason why people don't donate. Or we do have people who've heard about transplantation, but don't generally consider it for themselves. We see the percentage drop. This is a study that I did back in 2014 on the patients who were eligible for transplant in our unit. And then the ask is a big problem. They don't want to ask. And I think we have that problem in our culture where people are feeling, you know, they think their relatives should offer. And then the brain death, the knowledge about that is very poor. So I think once we get the legislation going on, we have to do a lot of PR. But I would say when it comes to people agreeing to be, this is again highlighting, this is a study by Peter Adams, our dean, comparing the knowledge about deceased donation between the UK and Barbados. You can see the percentage was quite low. And then, but very good, the willingness to donate was high, except there were some concerns that the doctors would do everything. So that has the part of the ethics that I think Harry spoke to, Professor Harry. You know, we have to be very clear and very transparent that, you know, all T's are crossed and I's are dotted, that, you know, people don't think you're just taking a patient off the ventilator for your own selfish purposes. This is us raising awareness. We just get out there. Rotary did a big awareness campaign in February. We were there speaking at the Rotarian meeting. I made the point better to ask than wait. I think Andrew Reddy said it well from TLC, you know, it's a time to be selfish. So you have to ask your relatives, and I encourage people to ask. Or if we can ask for them, that's fine, but you know, we can't just sit there and hope somebody offers. Oh, this was a fantastic PR campaign we had in February. The Baroness of the Charity came, Dame Florida. She's actually Trinidadian, but she's adopted Barbados and she loves Barbados. And she came and did a huge PR campaign. She spoke to the Prime Minister. She was on TV. And here she was a pair, a mother-daughter pair we did. And you know, the best PR are the patients, and then seeing them smiling and off of dialysis, and the donors being so happy. And there's Dame Floella giving her, we had a press conference with Republic Bank. Republic Bank has been a huge sponsor for us. They're out of Trinidad as well. And there's TLC, that's Nick and that's Jenny. Tremendous help from TLC. I would say a big part of the promotion is because we're busy working and doing the work, but when you want to do the promotion, it's so good to have somebody who's doing that for you. And that is where we really appreciate Jenny and Nick and all the group from TLC. And of course, they're the ones that push all the donation and request the funding because, oh, I want to highlight Barbadian. Also, Belma Scantlebury, the first Black female transplant surgeon. She's also offered to do a lot of PR for us in Barbados. She's Barbadian born. Legislation is crucial. So I would say this administration, our Prime Minister Mia Mottley, she is very pro-transplant and is setting up a program. And we're working now, it's finally gone to Parliament, and we're very close to our drafting this legislation. They've accepted it. That is required. And I think this administration, if it doesn't happen in this administration, I don't know if it would happen because they're so pro-transplant. And I think at least with the 30-0, you know, landslide, we will see them for at least another 10 years. So we're going to make the most of these next 10 years. Staff, I'm so happy we have, I think Natasha's on this meeting. We have a second surgeon training in Birmingham where Malcolm trained. He said he got his learned the technique of lap-assisted donor nephrectomy. So we expect that Natasha is excellent with the laparoscope and the laparoscopic techniques. We expect her back in April. And I think when she comes back, we will be fully up and running in terms of the skills that we need to do both surgeries. And so Malcolm, we appreciate your offer, but I think we're going to be okay. So, and we have 2 great nephrologists, and I said we have a coordinator. We probably could do with a 3rd nephrologist, to be honest, because our nephrologists are looking after about 1,000 patients with renal failure. And, you know, aside from the ones on dialysis, they're all the ones that are coming with renal failure to manage low clearance clinics and so on. But Natasha is training and she's getting all the experience, both in live donor and deceased donor currently in Birmingham. There's Natasha and I doing one operation. I would say with COVID, it's really brought home the fact that, you know, sometimes you have to be independent within your own country, because look how hard it is now to move around in terms of even between the Caribbean islands. There is Ruth getting signed off for her training by Nick. She also went to do her training as a coordinator in Birmingham. Funding, private, public. So we're out there, we're begging, because I mean, the government doesn't have much money and we recognize that. So we do our part to raise funds. Republic Bank, this is some of our sponsors. And we still have to sort of smile for the camera. We don't like it, I don't like it at all, but you know, this is the way that we have to. We have, Barbados doesn't have much money in the government, but we have people living here with some very deep pockets and in some million-dollar mansions on the West Coast. So we sort of appeal to them to help us and fund us and support us. And this is where, again, TLC helps in terms of getting us out there and motivating us as our shy doctors to go out there and ask for support. This was TLC. There's Malcolm. He came over in one of our first living donor transplants. And this is the group. There's Lisa Bell in the middle. That's our second nephrologist. And you just heard from Narissa. And there's Ruth in the background. This is the TLC team, and that's Andrew Reddy. He was the head of TLC initially. This team has shrunk down now to just a surgeon coming. And as I said, I think the skill transfer will happen very soon. So we're pretty much an all-female team so far, which is fine. We get along well. Future plans, we want to get the legislation going. We want to partner with DTI and Trinidad. Dave reached out to me and told me, you know, once we get going, he's happy to come over. I'm sure Malcolm will be as well. And Paul just spoke about the partnership with PAHO, which was really fantastic. And then we heard yesterday from Dr. Sharma raising awareness for the Commonwealth. There was DTI who came, Arancha, I hope I pronounced her name correctly. There's Hasina, she came and gave us a lovely talk last year. And Narissa spoke as well. I think that's Lisa there in the background. And here's Ruth. What a great meeting in PAHO. I really appreciate that invitation from PAHO to Cuba, where we exchanged ideas. It was nice to see other countries with the same problems, the Latin American countries. There we are. There's Patricia from Antigua. She's a deputy director of nursing, and there's Kishore doing great things in Guyana. We missed Trinidad at that meeting, and there's Paul who just spoke. Maurizio, I'm not seeing, oh, there he is, he's in the background. That was a really lovely meeting. And this is the Latin American group, very cohesive. Love to see their camaraderie. And this was Dave spoke about the schools and awareness. This was a lovely, in Cuba, where they had a competition with the schools about donation. I think that's where we have to target the young people. And this is what I miss with conferences, that, you know, going out to eat. I mean, Zoom is lovely, but it's nice that sort of after conference liming time. There's Curtis Yates. That was a really good time we had there. And this was us having a powwow after the conference. Strong conversation. There's Kishore. I don't remember what we were arguing about, and there's Curtis making some strong points to Paul. And after that meeting, we actually created a WhatsApp group. Most of the people on this involved in transplant are on it. And it's nice because we could just put things in the group, we get a quick response. I'm thinking maybe an IG page, this is sort of new things that people are doing. Instagram, I think, when I see that they have some plans for webinars, that's fantastic. This is a Commonwealth partnership that I hope we can be part of come 2022. And I just want to highlight in closing, Mr. Alan Haynes, he's right here. He's a transplant, he's a dialysis patient. He doesn't want to ask his family for a transplant. He's one of those. But he has a sister who's had a transplant for a long time. But yeah, anyway, he doesn't want transplant, but he's doing a lot in terms of raising awareness for kidney disease. And he's created a website called Kidney Caribbean. I would encourage everyone to visit. And this is why we get the great support, because it's the patients that are going to push this, because we can only do so much as medical practitioners. I think the patients are the ones that are going to get us going in terms of our program. And this is one of his pictures. They're all about the Caribbean. And I think this is where we have to go in terms of camaraderie and being together. Meetings like this and people like Hasina who keep bringing us together will get us there in the next, hopefully, 5-10 years. Thank you.
Thank you for that presentation, Dr. O'Shea. Okay, we apologize for going a bit over our scheduled time, but we are moving on to our final presentation for today. It will be given by Dr. Kishore Prasad, and he'll be presenting on a retrospective analysis of transplant in Guyana before and after 2014. So Dr. Kishore Prasad is a transplant and vascular surgeon at Georgetown Public Hospital, Guyana. He obtained his Bachelor of Medicine, Bachelor of Surgery, and postgraduate in surgery at the University of Guyana, and completed his transplant and vascular fellowship at the Foothills Hospital University of Calgary, Canada. Over to you, Dr. Kishore Prasad.
Hello?
Yes, we can hear you, Dr. Prasad.
Yes. Okay. Can you see my slides? Hello?
Yes, we can. You can go ahead.
Good morning, everyone, and special thanks for this opportunity to present to you all at this conference. My name is Kishore Prasad. I'm a transplant vascular access surgeon at the Georgetown Public Hospital. Today I'll be presenting to you a retrospective view on transplantation in Guyana prior to 2015 and what happened after 2015. Before that, I'll just introduce you to a little about my country. This is a map of Guyana, usually known as the land of many water, but now it's usually known as the land of many oils. Guyana is approximately 83,000 square miles with a population of 750,000. We have 6 main ethnic groups, and we are the only English-speaking country in South America. Our main natural resources are gold, diamond, bauxite, rice, lumber, and oil, for which we have made a lot of friends and the international market of recently. We have a lot of landmarks, and one few should know is the Kaito Falls, and it's the largest single water drop in the world. So we have the largest floating bridge in the Caribbean, and that's the Demerara Harbor Bridge. And we also have the tallest wooden structure in the Caribbean, and that's the St. George's Cathedral. And of recently, we had a lot of political fights and in the economic arena because of the oil. But this is a picture of the surgical ward at the Georgetown Public Hospital, to which I returned in 2015 after completing my fellowship in transplant and vascular surgery at the University of Calgary in Canada. And here I was tasked with the opportunity to develop the transplant program for the said hospital. Before 2015, surgeries at this hospital was basically done by a foreign team from the US. And they basically, what they did is that they come in periodically, they would perform the transplant and they leave after. After we returned in 2015, we were a small team. And to understand our success, you need to understand where we came from. Prior to 2015, transplant in Guyana was done mainly by foreigners, and it was mainly done in the private and in the public entity. The first kidney transplant in Guyana was done in 2008. And by 2014, approximately 30 cases of renal transplant were done. But to actually understand what happened prior to 2014, you need to understand the settings that was actually in Guyana. They were never a dedicated team. They had no transplant database. There were no constant supply of medication and no drug level testing. And what we did is in 2015, after we came back, we established a transplant and vascular department. And currently that consists of 2 vascular surgeons, myself and Dr. Carlos Martin, along with another general surgeon, Dr. Roy Samlal. We currently have 4 senior house officers that work with us in the transplant department. And they also take up the role and responsibility as functioning as our pre-transplant and post-transplant coordinator. Note, we are limited in resource and we try to cover all aspects of transplantation with the resources we have. We have a secretary attached to our department also. The picture here is depict the first kidney transplant that we have done in 2015 after we would have returned into this country. The big answer and how this came about was because of the word no. After we would have returned to this country, we would have asked the team from the outside team that used to come to Guyana to help us because it was new for us to embark on transplantation in Guyana. And they blatantly refused to partner with any one of us because they were more interested in doing the transplant privately. However, thanks to them, so we end up developing our team locally and we proceed to do our first transplant in Guyana, the Georgetown Public Hospital on that set year. So this was basically the team that did the first kidney transplant, myself, Dr. Pruhit, and Dr. Mahad, you could see in the picture. We did not stop there because we realized that transplants, there's a limit and we do not have legislation for cadaveric donor. And because there are multiple patients who have donor and just they're non-compatible, we then proceed to do our first pair exchange transplant. And we did first pair in 2018, and we did a second pair exchange transplant in 2019 successfully. This picture depicts one of the paired exchange kidney that we would have transplanted. And that's after we would have completed the venous anastomosis. So, like I said before in this presentation, before 2015, that's between the 2008 to 2014, 30 renal transplantation was done in Guyana. And from 2015 to 2020 so far, we would have completed 28 cases of transplantation. To understand what happened to the patient prior to 2015, and I will show the data shortly. You need to understand the story of Paul Walker, and I would have presented this before, so some of you know that. So what you see in movies such as Fast and Furious, and where the fictions of life does not really translate into the reality, because if you do not follow principle and protocol, you will end up like how Paul Walker did. And that is exactly what happened to the success of transplantation and the results that happened prior to 2015. 15. So within the 6-year period, 2008 to 2014, they would have done 30 transplants. And when we did analysis in 2014 and look back at what happened to these patients, almost 83.7% of those patients had died. When you look at, after we would have intervened and set up the program with our limited resources, and we would have have a dedicated team, along with ensure the adequate provision of medication on a constant basis. We also partner with Miller's University in Miami to do all our transplantation tests that we would have needed. And we would have utilize all resources that we can obtain from University of Calgary. We so far would have performed 28 transplants, and we had 4 deaths, which is account for 13% of our case. One of our patients, he had an acute myocardial infarction. The second patient, one committed suicide. The third patient, he died from sepsis in Suriname, and that's because he had an abscess in his cervical spine. And the fourth patient died from a massive pneumonia in the intensive care unit of the Georgetown Public Hospital. As a small team, we continue to progress over the year. And we started off small. We had to prove ourselves and then to show what we can do, and then we progress. So in 2015, we just do 2 cases successfully. Then we move on to 3. In 2017 and 2018, we did 6 and 8 cases. In 6 and 7 cases, and in 2019 we did 8 cases. Like everyone, the pandemic would have affected us too, and we had only managed to do 2 cases this year. However, by the end of 2020, the graph will look like this, and that's because over the next 6 months, over the next 3 months, we have 8 cases that is currently scheduled to be performed, starting from the 2nd week in October. And 2 of those patients will be another pair exchange transplant. So by the end of 2020, our graph will look like the current one you're seeing currently. Our young program, you want this like every other program, or we have a 0% mortality, which is consistent because, like Dr. Malcolm said, 1 death from a donor will actually shut your program down. Well, so basically, in summary, we would have, in the last 5 years, we would have done 28 cases successfully. We currently have 39 patients registered in our transplant clinic. We had 4 deaths in the past 5 years. 95% of our patients are back at work and they are studying. All our donors are leading a comfortable life, and we have a 0% mortality rate. Like every one of you, the factors that affect our living donation are ABO incompatibility, antibody sensitivity. Patient come, they have no family member or relative to donate to them. Public awareness still remain a challenge, and education of the general public is something that needs to be expanded upon. Factors affecting the growth of our program in Guyana. Currently, we have no legislative framework for cadaveric transplantation. This is something we're currently working with the new government of Guyana through the Ministry of Health. And we're hoping that PAHO, along with WHO, will help us to acquire this legislation so that we can move forward into cadaveric transplantation. I do understand my colleague Margaret also, they are working on it. So we are willing to have any help to move forward with this legislation. Tissue typing and cross-matching, we do not have that capability in Guyana. Hence, we would have partnered with Miller's University in Calgary. Also, Miller's University in Miami, and the University of Calgary also help us with some of this, and they help us with drug level. We are now also able to do tacrolimus drug monitoring in Guyana. All our CMV and BK virus testing are done in Miami, and we have access to the lab, so we have our results in a rapid fashion. Public education and awareness still remain a big issue that need to be addressed. And we're hoping as time progresses, we can, together with the help of the government and the media, we can make this more knowledgeable. And a big thing is the politician acceptance and awareness around the Caribbean. Don't take your politician for granted. A lot of time they do not even know what is the benefit of transplant. Thanks, everyone.
Thank you for that, Dr. Prasad. So we're moving on to our question and answer segment. We will start with the questions posted in the chat. If you haven't done so already, you can post your questions and we can ask them. Okay. So the first question I'm seeing, addressed to Dr. Gomez. What do you recommend about HLA typing and cross-matching facilities? Do we need in each country? This question is from Dr. Roberts to Dr. Gomez.
Yeah, hi, good morning again. And thank you, Dr. Leslie Robert, for the question. I will recommend, or I will say that it's not needed that each of the countries develop their own tissue typing lab, no? This is why we are talking about this collaborative network. So just to give you an example, we here in Catalonia, we are 7-8 million of habitants, and we have only one tissue typing lab, and all centers send the samples to that lab. No, of course, it's not a similar situation, especially because we are talking about different countries and distance. So, but my recommendation will be to have maybe 3 tissue typing labs in different locations, and then try to concentrate all the activity in these 3 labs.
Thank you. The next question we have, what mechanism is being used to identify potential donors and track their condition in T&T? I don't see who it's addressed to, so maybe Dr. Samuel, you can take that question.
Well, I'm not quite sure what the object of the question is, but I am assuming that they're trying to find out if keep an eye on the potential donors. But not really. I mean, donors come in 2 categories. They come as a potential live donor for their friend or their relative. So we assess them then. If it's the patients who are on the deceased donor list, then you actually don't really follow them up because these are people who volunteer, they sign up. We assume that they are medically fit because we don't do any kind of clinical assessment or exam. We issue them with a card, and we encourage them to speak to their family so that their family would be aware of their choice. So we don't really assess them or keep on tracking them. Now, if one of them ends up in a situation where they are to be considered as a potential donor, then we will make the assessment on the suitability then. But we don't really do any tracking or follow-up of our donors who are on the donor registry.
Okay, thank you. The next question is for Dr. Jurawan. Do you believe that in low resource settings as ours in the Caribbean, where the exchequer covers the costs of dialysis, that we should have a peritoneal dialysis first policy as occurs in Taiwan and some Central American countries?
So to answer that, I can see the value in it, but I'm not one to take away patient choice. I work as a team with my patients, and so, you know, all I can do is advise, and they actually have the final say. So I would not be happy to enforce something like that. However, what I can say is in the Caribbean, what we need to do is promote greater awareness and education of peritoneal dialysis and get the programs going, rather than, you know, making it this is first and hemodialysis is second, because, you know, there are patients that are going to have that may have absolute contraindications to peritoneal dialysis. And as I said, I work as a team with my patients. I don't tell my patients what to do.
Okay, thank you. The last question I'm seeing is, does Barbados have a transplant law?
So I think Dr. O'Shea spoke about this, and currently we are in discussions, and it is hopefully going to be passed soon in Parliament with the present administration. So we are looking forward to that, so we can get our deceased donor program up and running.
Okay, thank you. We may have a few minutes for a few more questions if anybody else has any questions, any of the presenters.
Can I know Nerissa, I just want to get back to Sean's question, the question about PD choice. While I hear what Nerissa is saying in terms of not prescribing, I think unfortunately in our context, and speaking as coming from St. Vincent, where resources are even more stretched, I think sometimes patients are not necessarily their own best decision makers. So sometimes we may have to prescribe. If you have somebody who actually fits and would do well on PD, sometimes it might be useful to just encourage them. You don't necessarily force them, but you kind of encourage them to consider that. Because the last patient we did here 3 weeks ago, she actually was on PD and she was fantastic. She was a head teacher, so I suspect that helped to make her decision. But she was in very good condition, you know, and the only frustration she had was the machine beeping off at night, right? But I think we underutilize PD. And I think Sean's point is valid, so I wouldn't quite, I don't know if he was suggesting prescribing or forcing, but I think he was saying that we probably need to advise patients a little more persuasively.
I agree with you, and that was the point of my entire presentation. That's what the problem with PD, again, is there's a lot of misconception. Patients are afraid to do this therapy on their own, so it requires a lot of intensive counseling. I mean, and the key is to catch these patients at stage 4 and stage 5 and start talking to them from then, not the crash landers that we're seeing on the board and they're terribly afraid. So once you start that counseling early, trust me, we get a lot of patients onto PD, and that's the way to do it, in a very gentle manner, rather than saying, and I mean, and sometimes we are forced, I mean, my hands are tied sometimes because I just can't have anyone else on hemodialysis. So I say to them, please do the PD. This is the best option for you. You're getting, you know, every night as opposed to just twice a week. And they do understand, but it requires a lot of counseling. And that's where, you know, PD nurses come in. It's crucially important, because the thing is, the PD patient is separate, is different to the hemodialysis patient. The hemodialysis patient puts a lot of responsibility on the medical professional, whereas the PD patient is very self-empowered. You're telling me your patient, you know, she's a head teacher. I'm not surprised, because these PD patients are very motivated. They actually will, they will do better on transplant because they take more of a lead in their life. So they are the ones that will actually go out and get donors and will be transplanted a lot quicker because of that. But on the flip side, if you know, I've tried patients that absolutely don't want to be on PD and they just tried it. And what has happened? They stop doing it. Their cleanliness is awful because they just they don't want to do it. And they have forced my hand now into converting them to HD. So it's a fine line, but I think the key is to awareness and of course the counseling.
Okay, thank you. I see Dr. Lynch has his hand raised. You have a question?
No, I just wanted to make a statement with regards to, I mean, all of us have trained in first world countries, and that's great. But, you know, I've started looking at you know, looking at third world countries and policies, because we are third world countries and we don't have the resources as to some of the countries that we train. So, I mean, my question really wasn't one of forcing or something like that, but, you know, and of course, if there's a contraindication to PD, of course, those patients have to go on hemodialysis. But I just started thinking about this really because it is a policy in Taiwan, for instance, and I think it's in Guatemala they do it, where they say, hey, listen, you have renal failure, you're eligible for PD, we'll pay for PD. If you fail PD and you have to go into hemo, of course, we'll pay for it. If you can't do PD and you have to start with hemo, of course, we'll pay for it. And they have been able to at least what they project, I don't know for sure, but at least what they present is that they've been able to better utilize their healthcare resources, better able to get patients dialyzed. For instance, I think it's far better having a patient on PD than on twice weekly hemodialysis. I mean, that's not standard of care. So, I mean, I just throw it out there. I know it's going to be a kind of controversial thing, just to open the discussion as to where our thinking should be and whether, you know, we naturally tend to go towards first world country guidelines because that's where we train, that's what we know. But should we also be looking in different directions? And even in Toronto, for instance, even people who could not physically do it, what we had was a program where the nurses will go into patients' homes, and most times those patients will be on automated PD, and they will set up their dialyzer machine, their cycler at night for them or whenever, and you know, so the patient doesn't actually even have to participate because the government recognized then that this form of therapy is so much cheaper, it's providing the same outcomes, and we can hire a few nurses, give people jobs and stuff, and still save money and still provide same quality of care. So I'm just throwing it out there just to, you know, kind of throw it out there because I see even with us, even with our universal dialysis program, you know, the cost is becoming astronomical. And at some point, somebody's going to ask the question as to how could we afford this any longer and what options do we have?
Sean, I completely agree because my go-to is peritoneal dialysis first, as I explained in my presentation. Again, because we are where we are, we can't do assisted PD as I was accustomed doing in the UK. I don't have staff to send to set up a machine. We are heavily reliant on the family members, and you know, that's where we are. But how is it in Trinidad for peritoneal dialysis? How is that program? Out of curiosity.
So here, you know, since we've had, you know, like Anisha and Anna's and all of them come back, and we've had a lot of new nephrologists, our PD program has taken off. I mean, these guys have really made a significant difference. I mean, the other day I went into our PD unit, and I think we are up to 70-something patients, and that's just in Eric Williams, you know. And I was like, wow, we're really doing well. We've really pushed PD. It's gone up. It's really taken off. And to be honest with you, for the first time, I think we have the medical staff to deal with far more patients. What we do lack is a bit of nursing staff. But to be honest with you, at least in Eric Williams, what we've done, if they started rotating all the hemodialysis nurses through peritoneal dialysis, so each of them is getting that experience. So we are training up staff, and that's why, you know, I think we finally at the point where we can start thinking about these sorts of policies and stuff. And the PD program is fantastic. I mean, the fluid is dropped off to the patient's house. Bride and Pie, who has the contract, they independently hire 2 nurses who will be a go-to person for these patients, and they sort of serve as a link between the nephrologist, the nursing staff in the hospital, and the patient if there are any issues. It's really a fantastic program. I mean, every time I have a PD clinic and I carry new residents there, none of them believe any of these patients are actually on dialysis or they're sick. Yeah. They look fantastically well. They do fantastically well. And I think that is something that we can really be proud of, that has improved, not because of anything to do with me really. Honestly, it's because of these new guys who've come back. They've really pushed the program, and it's really fantastic to see it actually.
Yeah, it's similar in Barbados with Bryden, and Yeah, it is. Our program here is fantastic also. And I do think, I agree with you. It's just that I don't want, you know, yes, it's a policy, but I don't want it to be set in stone that you have to do this. I think patients should still be given the option, but we should push peritoneal dialysis, especially with all of these transplant programs.
Dr. Gomez, you had a question?
Yes, thank you. Well, more than a question, or well, this is a question for all my colleagues from Trinidad, but also from Barbados and from Guyanas. And it's in regard of this idea of this network of collaboration for organ transplant, no, from disease donation I'm talking about, no. If I just would like to know about your opinion, and if you see this happening in the future, the possibility that you can share recovery teams and recipients and organs.
You want me to take that?
Sure.
Well, logistically, I think there are a couple of things we're going to have to, if you're talking about recovery, I presume Maria, you're talking about retrieval, organ retrieval, yeah? Yeah. I know in the presentation there was talk about where you compare the sharing networks, and the fact that the country that may generate has the first choice. That is probably not going to be feasible in Eastern Caribbean, for example, because, I mean, let's say hypothetically, if I go to St. Vincent to retrieve, there's no way I'm going to transplant a patient in St. Vincent, right? Because the facilities, the post-op care. So what is going to happen, unfortunately, is that deceased donation is going to have to be regionalized. It's going to have to be regionalized to a center. So the larger centers are going to have to, are the ones that are going to take the organs. However, what can be done is, for example, if you go to an island, say Grenada or one of the other islands, even Barbados, is if we're coming up and we retrieve, we will say, okay, we can put one kidney in there, and we'll take one kidney to Trinidad, or if you go to one of the smaller islands and they have a patient, that patient will have to come down in terms of having the transplant done, because there really is nothing in the much smaller countries, in the smaller islands, to facilitate deceased donor transplantation. In fact, well, for the small countries, even live donors, so they will have to go to a center. Because you're talking about cross-matching, tissue typing, you're talking about drug levels, and if we run into a problem like what Narissa ran into earlier this year, where you have somebody who has acute rejection, you need to have a biopsy, a pathologist to interpret. So you're looking at a crazy logistical problem in terms of any type of organ sharing or organ team sharing, retrieval, etc., etc. It's I don't want to sound pessimistic, but as a person who's trained in the Caribbean, who's worked in 6 different countries in the Caribbean, I know the politics, and it's going to be Mount Everest. That's all. I don't know if anybody shares my opinion or my innate pessimism, but I don't know. It's gonna take a lot of work.
Okay, thank you, Dr. Samuel. Dr. Lynch, you had a comment?
I'd say I think it's fully workable. I mean, I think we need to start thinking small. I mean, what Malcolm just described is the holy grail, eventually coordinating for organs. But we could start even smaller. I mean, I mean, to be honest with you, I wasn't aware of some of the other work going on in the Caribbean islands. I mean, I'm watching Dr. Prasad's presentation with Guyana, and he's saying that they send their stuff for tissue typing to Miami. Now, why it is that they can't send it to Trinidad? We have a tissue typing lab. Yes, we have issues with reagents, largely because of cost. But I mean, if we start providing a service, which I think is would be cheaper than going to Miami, and we able to generate some income, then we can start even having the resources ourselves to determine and get our own supplies rather than waiting on the government. But we have the staff there, and we have the tissue typing facilities. So we could start with something as small as that, something as small as expertise, our expertise is different in each island. And I think eventually over time, and when I mean time, I could foresee this taking a long time because it will involve legislation. And we know slow legislation moves in the Caribbean, particularly in Trinidad. I think the other countries are far better at it. Because to move organs between countries, you will have to have some overriding legislation. But I can see it, eventually reaching to that end. And I think we need to start small, and eventually, it probably might be beyond my time, see something come to fruition where we can have actual organ sharing moving across borders.
So,
Dr. Lynch, hello.
hello?
Hey, so Dr. Lynch, I do appreciate the fact that you make the point where we can utilize Trinidad for tissue typing and cross matching. We would have made that contact some years ago, but apparently they said we have to work through the minister or the ministry there, and that fell down somewhere. So we are happy at any point to partake and to send our sample to Trinidad in that. To respond to Ms. Gomez, Dr. Gomez, in terms of organ sharing through the Caribbean, I think the first thing we need to work on is that to ensure that each one of the country that is partaking in transplant to have their independent legislation. That first will cover us, and then we can move forward. Because once each country can obtain their legislation, that will allow them to move forward with cadaveric transplantation, then we can then work together for the overriding legislation to help us to share organ. And that will allow us where if Lois said someone come to Guyana to help with harvesting, one kidney can be transplanted right here, one can be taken back to Trinidad or Barbados. And I think the groundwork needs to be done. And that's why I commend PAHO and WHO when they were actually moving forward to have the universal legislation to cover the Caribbean countries.
Okay, so we'll take Dr. Jerwan next and then Dr. Valeron.
So I just want to say that I agree completely with Dr. Bishop. By the way, I'm very impressed with Guyana and Dr. Lynch. Malcolm, to do my job, I have to be the eternal optimist. So it is my dream that we do share organs. That was my dream in coming back to the Caribbean, because this is a resource poor setting across the board, the entire Caribbean, and we stand to gain more if we work together rather than have all of this politics or competition. We do, and it can happen. And I agree with Sean. We start small and then we grow.
Okay, Dr. Valeron.
I agree too, just before the other person speaks. I'm being optimistic as well. So I think the hospitals that can do transplant, that we have deceased donation, the kidneys can be put there. And I think it can work. And even this meeting is making me feel more optimistic, despite Malcolm being a grouch. I think we have to put our heads together, and we need a legislation, and our legislation here takes a long time. I don't know, Sean. We've been at this now for 20 years.
Margaret, I'm a grouch with experience.
I hear you.
I've been in this for 15 years, so
I agree.
I'm not speaking as a Johnny come lately, but
you're a Scrooge.
I'm a surgeon. I'm a realist.
Yeah.
Fair enough. But you gotta get some of these nephrology genes. You're going to get some new genes from a nephrologist.
No,
They
no,
never
no.
give up.
I'm an optimist. I'm an optimist as well, but I'm also a realist. And Caribbean
I just want to
interaction is
clarify the case that you point out with St. Vincent. This idea is not looking for in every country or a small island they perform transplantation. In the case that there is a donor in this small country or island, the donor the organs will come to the countries where transplant program exists. That is the idea. Basically, the idea is not that each country in the Caribbean region develop a kidney transplant program. This is not needed. It's not needed. You can support each other. But it's needed that each country in the Caribbean region have their own pool of recipients, potential patients in waiting list that of course will be transplanted in Trinidad, Jamaica, Guyanas, Barbados, in the places where already exists a transplant program. No, just to comment on your case, no, that you referred before. Sorry,
Okay.
and thank you for
sure. No, that's fine. That's fine, Maria. I agree. I take that. I hear you.
I think somebody has their hand up. I jumped in front of them.
I spoke to them, but they didn't
Oh.
respond. So are there any other questions? Any other questions or comments?
No, it's lunchtime.
Make a comment, please.
dinner time here. Not too early for the dinner in Spain. Maybe
Okay.
snacks.
Siesta.
This is Paul Edwards from Paho. Can I make a comment?
Hi, Paul. Yeah, go ahead.
So would we say, based on the last 5 minutes, that legislation is #1 priority for Caribbean countries?
Amen to that.
Yes.
All right. I have a resounding yes. I'll take that to the authorities who should take some action. Thanks.
Thank you.
And have a great day. Bye-bye.
Well, please
Bye.
keep us informed in what step you're making so that we can work along with you to help you in whatever way we can for this. Because I think Barbados, Guyana, and the other Caribbean country who's lacking in legislation, that is something that is holding us back from progressing, and we need it desperately.
Okay.
Could I just say something quickly?
Sure.
Sorry for the interruption of it. I'd just like to make a unbridled request. You know, this meeting this weekend has really inspired me, to be honest with you. I seriously did not know what was going on in the rest of the Caribbean. And I really think we have to start coming together. I'm really for that. And I would just like to invite myself, so with any other countries, whenever you guys doing transplants, if you could invite me, I'll pay my own way, I'll come. I just really want to see how it is there over in that sort of setting. And similarly, if anybody wants to come when we doing our transplants, we're happy to have you on board. Because I think that's where things need to start. We need to start developing those sorts of relationships, and then we take it from there. You
need to open your borders.
Well, it will eventually open.
Trinidad will not.
Please, I want to come home for Christmas.
I'll have an excuse to come to Barbados again to visit your beautiful country. So I just want to say that, and I would want to put out the invitation. I mean, we're actually having a transplant in 2 weeks, on the 29th of September. We're having one, and we're probably going to have, we have about 3 people already lined up for the end of at least till the end of the year, probably more. So, but the borders is an issue. I'm looking beyond that. I mean, COVID will eventually die down and life will come back to normal at some point in time. But yeah.
Yeah, Sean, we will take you up on that. We will invite you to Guyana at some point.
Yeah, Kishore, I can come and start teaching you the hand-assisted lab. So.
Malcolm, well, we will welcome you with that, sir.
He's
Thank you.
very skilled in it. I would have to agree.
I haven't been to Guyana in 42 years, so I need to come back.
So, Malcolm, we currently have, in the next 3 months, providing our borders are open, we have 8 transplants. 8 to 10 is actually scheduled to be happening, and that's for the remainder of the year. And we have 21, in all 21 cases. So, thanks, sir. I'll be looking forward for your assistance.
Yes, I'll send you the list of instruments that I need.
Thank you.
Okay.
Okay, so I see
just quickly, I just want to emphasize what Sean has just said, because Margaret knows that as long ago as 2016, when I presented in Barbados, I did make the point. I did, during my presentation then at a conference they had at your conference center.
Yes, yes.
Calendar, right?
Yes, yeah, I remember, yeah.
I did make a plea for us to work together and come together. You have a standing invitation to come here.
Thank you.
I actually think it might be beneficial if you actually come whenever, when the borders open, to come and see a deceased donor retrieval.
Yes, I would love that.
I think that would be certainly beneficial.
But that would be very short notice.
Yeah, it's going to be short notice, but I mean, generally do it late at night, so you can always jump on the 8 o'clock flight out to Trinidad, out to Barbados. When the borders open, you can jump on the plane, come see it, and you can go back on the first flight the next morning.
Great.
But yeah, so I haven't seen or heard anybody from Jamaica around today. But I think
Curtis was in Cuba, but I only saw Soyembo on this meeting.
Yeah.
I don't know if he's still here.
I'm a nephrologist, but I think we need to involve Jamaica as well in whatever cooperation. I have been working with Curtis in Montego Bay for about 6 years, and I went to Kingston last year, and it was good to see, things being started. But yeah, I mean, and also I have 3 colleagues, 3 transplant surgeons in the US, 1 Jamaican, 1 Dominican, and a Trinidadian. And I know for sure that they will be willing to work with us as well going forward. And I think we will be able to develop our own cadre of Caribbean and Caribbean diaspora surgeons and nephrologists moving forward.
Okay. So that brings us to the end of our meeting today. I will hand over to Dr. Hasina Mohammed for the launch of the Transplant Series monthly webinars. Dr. Hasina Mohammed.
Hi, can you hear me?
Yes, we can hear you.
Yes.
Okay, so I'm just going to share this. This is going to be literally less than 5 minutes. So what the launch of the Transplant Series, yeah. So the launch of the Transplant Series, basically what we plan to do, it's a collaboration between the T&TMA, NORTU, and the DTI from Barcelona. And it's not just a Trinidad thing, it's a regional program, it's also international. So what we would like to do is, I just got a message saying we've planted a seed, and I'm glad that seed is there. So we're just going to kind of water it and make it flower. So what this monthly webinar is that we plan to do these webinar series, and it will be the last Tuesday of every month. There would be a link sent out so that it's, like I said, the speakers, we don't have all the speakers yet, but we have potential topics. So we've reached here. So this is the 2nd Caribbean Summit. And then next we'll be doing, and this is on the 27th of October, it's a really special day, that's my birthday. But we'll be doing that, and we'll be talking about the renal program in Barcelona. And then we have all the way down to different topics. Now we do have legal issues inside of here. I know legislation is a big topic, and we had a huge discussion on it today. So that will be addressed by everybody. These are these are the tentative topics, and we go all the way until May 2021. But these are not the only topics. We have a mixture of nephrologists, we have surgeons, we have psychologists, we have nurses, we have coordinators. Everybody's inside of this conference, and we would like everybody to have an input on what they would like to know or what they would like to hear about, and we will be able to put experts to that topic so that everybody can have a say and an input and discuss what's going on in different countries, different regions, also internationally. So this is what our Transplant Series launch is all about, and we will be sending the link for you when you want, if you have any topics that you would like to know, if you want to get your name on the mailing address, this is my contact. You can WhatsApp me, you can message me, you can email me, you could call me, and we will put you onto the webinar list of topics, and we will get it done. I don't want that it fizzles out in the end. We want to just keep this going. We stopped at May 2021, but we want to continue 2022, 2023, and see how far we can go. We can only grow from here. So this is what the webinar series is all about. And I'm just going to stop sharing my screen here. Before we end, can I ask that everybody puts on their camera, because we would like to take a group photo shoot. So pajamas and everything, we're going to take pictures. So everybody cameras on, and let's just take some one huge photo shoot with everybody. Yes. Maria Paula. I don't want just the speakers, everybody, attendees, everybody. Come on, cameras.
Smile.
Christina, you have us blocked from opening our videos.
Do I?
You cannot start your video because the host has disabled it.
Okay, how am I supposed to?
I can't turn on my video. You have disabled it.
Okay, just 1 second, please. I'm trying to figure out how to unblock it. Thank you. Hold on.
I'm taking so many pictures. So
Maria Paula, how do I unblock everybody's camera?
okay, let me see. How can I help you from here?
Oh boy.
I don't know.
I have been unblocked and I was allowed to start my video and my mic.
Okay, well, that's good. I don't know how that happened. I'm going to keep doing this.
We can see you, Bridget.
Okay, I'm taking.
Can't get mine. Are you seeing me?
Yes, we're seeing you.
You can't see me.
Just hold
You
on.
are?
You have a mask on and glasses.
You have a mask and
I'm looking really terrible.
Okay, who else is still blocked?
Will you share the picture with everyone by email, or well, I have it, so I will forward to you.
Sure. Did you take the picture already?
Yes.
Hello, we have a body on the funeral home is here,
I
right?
can't see myself, but
I did.
And
Take off the mask.
transfer to the
Oh no. Hi.
I request a transfer from ICU to AGU.
Hi.
Okay.
Yes, I did. Yes, sir. And plus the funeral home is here for a body.
Take another photo, Hasina.
Oh, sorry.
Oh crap.
Okay, done. I took many photos.
Yeah, this one is dark.
Okay. Is that it?
It's done. It's done.
Did you get everybody?
Yes, yeah, almost everybody. There are still some cameras off, but almost everybody was in the picture.
Okay, great. Oh, wait. Dr. Roberts is blocked. One more.
Okay.
Yes.
Where is Dr. Roberts? I can see.
Dr. Roberts.
Was that you, Fasila? Camera's really dark.
Okay. Christina, actually,
that's it. So I just want to tell everybody thank you very much for attending. So this is just the end of it, the vote of thanks. I would like to thank all of those who participated, all my speakers. Like I said, a wealth of knowledge. It was a great conversation. We had a very good back and forth. Everybody got to share their ideas, their thoughts. I'm very grateful for that. I have to thank my supporters, especially Dr. Sammy, and Dr. Sandy, they have been guiding me through this technology thing. I'm a super 10 kind of person, so figure that out for me, Anthem. I do want to thank my moderators, Dr. Sandy. They've really jumped in and helped me at the last minute, and I appreciate it very much. I actually just put their names there and they didn't know. And Dr. Maria Paula Gomez, thank you so much. I know it's late in Barcelona. You're about 6 hours ahead of us. Thank you so much for staying on, joining with us today. My friend is off, but he was here from the Philippines and he's actually 12 hours ahead. So it's midnight by him now and he just left it. So I'm really grateful and very thankful that you all could be here. And the whole idea is just to bring the Caribbean. We all have our idea on transplants, but I would like for us to kind of bring this idea together. And once we bring it together, that is what's going to create our sharing system and our network. And it's just going to make us only better at transplants in the Caribbean. So we're not only going to be talking about Euro transplant, we're going to be talking about Caribbean transplants. And that's the aim here. So like I said, that was my contact. Send me what topics you all would like to hear, who would like to present. We will find experts in that area for you. Plus, we will also send out emails, invitations to the links to join these presentations. It's the last Tuesday of every month. It would be about maybe an hour and a half long. And if the conversation is really good, maybe 2 hours. And then we'll just continue as a team. So thank you very much, everybody, for attending. I really appreciate it. It's lunchtime now, so we could all go and eat. Yes. Bye, everybody.
Bye, Hasina. Thank you, Hasina, from the Philippines.
Welcome.
Bye. Take care. Get home safe, everyone.
I think I missed the photo. My phone discharged.
Emma, we must
Don't worry, when you come to Barbados, we'll take a next one by my favorite beach.
Bye, everyone. Great
Bye.
conference.
Shucks.
Bye, Dr. Lynch. Great job at No2. Continue the good work.
Thank you. How to get out of this?